from, but then Swami said this is called Karuna. Karuna in Sanskrit means infinite compassion, which is what this temple of healing expounds and stands for. Echocardiography is actually what we are talking about here. As physicians, we all believe that it is the invention, probably in medicine of 20th century, because the amount of clinical impact it has made, saving lives, which you can do repeatedly, less radiation, safe kind of procedure, is extremely important in today's world, particularly point of care ultrasound, which Dr. Balwasa will also be talking about. The essence of space also lies in that all of you as physicians get different levels of exposure to patients, both in terms of clinical exposure as also in terms of hardware availability. And point of care treatment, whether it's ultrasound or even on labs, is taking over the whole world today. All patients are the same to Swami, so we thought we should bring this wonderful modality to you, because we believe even one life saved is a family saved. There are a lot of focus experts here, since it is a focus-based conference, who will actually guide you beyond books with their practical life cases and their teaching. This is the galaxy that we all live in, but we have our own side galaxy, 10 of the rarest gems in this world, whom I adore and really learn from. They've all been my teachers. Let me start with one by one. I welcome Dr. Bruce Kimura, Dr. Keshav, Dr. Vijay, Satish Govind sir will just join us very soon, Barwa sir, Dr. Das, Iyer sir, who's been really our teacher, friend, guide, inspiration, everything. I can call him at 3 in the morning and he's still tired. Sunil, and of course, Cameron will join us soon, and Dr. Peter. This is a very special edition this is a very special slide for me. The next 2 slides are very special for me. All slides are, but I wanted to introduce this because this is the reason we did Space 2022. And the reason is this, that it is actually a tribute to all of you people. A lot of my own students here and staff at Swellsport who've been flu fighters for the last 2 years. They are those heroes who don't wear capes. We changed the way we work, the way we dressed up, the way we sweated inside. And thank you all for going above and beyond the call of duty, because a lot of us, as we said, cardiologists became COVIDologists, all of you became COVIDologists. We serve the nation in crisis. Thank you all for that, and for that you deserve the best, so that you will make up for all that you lost in the last 2 years not getting adequate exposures. So we'll help you with whatever we can in this conference, so that you go out more clinically trained at what you started off. So I welcome you all to Sathya Sai family. As we call it, it's a space theater. It's endless, just like space is. That's why we named it Space. Please make the most of it. And this is your conference. Try to contribute, try to participate. We will all benefit from it. With this small introduction, I request Balwasa to please invite the faculty and the guests. Sathya Sai.
Good morning, Sairam to all. My humble pranam in the lotus feet of my Swami, Bhagavan, Sathya Sai Baba. First of all, Dr. Praya has already told basically what is this program all about. And just on behalf of our cardiology department, I'd like to welcome you all to this special second edition of our conference. And especially I'd like to mention a few names. Dr. Bruce Kimura, who is the professor, director of the San Diego Script Clinic in Ultrasound. And he has done a lot of work, showed us yesterday some beautiful pictures during cardiac arrest, how ultrasound can help us. I always think that we sometimes terminate CPR very soon. There's no way to guide. Patient is not responding, we stop the CPR. But I realize, Professor Kimura has shown yesterday, that some of the people, if we have clinically looked at, we have stopped CPR. But looking at the ultrasound, they continued. Patients survived and went home. So I think it's so much emphasis that we have to put on the ultrasound, which is the bedside and point of care. It doesn't take much time. We don't have to wait for antiprobianty. We don't have to wait for CT scan. With no radiation. And Cameron, I think your daughter, she will join us soon. Dr. Keshav Nayak, really special to me, with medical director of structural heart program at SPIFS Clinic, San Diego. I learned some tricks during intervention cardiology when he first came here 10 years back. He is a strong supporter of Swami Vision. I don't have to elaborate on that. And will always do. They have come all the way from the other side of the world. For what? Not for their name. They don't need any extra name or fame. They have come to help us, to show us, to guide us. And Dr. Raj Prida is a well-known structural intervention echocardiographer, which is a totally new field. This recent publication from AFC, January 22, they are saying some new views for 3D, which Dr. Veera is going to talk about. And we have to learn a lot about 3D. And Professor Satish Govind, I think he's coming very soon. He's the doyen of echocardiography in India. No echo conference is done without Satish Govind. And Dr. Vijay Krishnamurthy, who is from University of Rochester in New York, is an intervention cardiologist. He does a lot of intervention TAVR, and he has been coming here almost about 10 years now. And when he was a fellow, he started coming here. So, what is the attraction? Swami brings all of us together there. And Dr. Sunil Bora, I think he's not come here. He's from Hospital, the chief of internal medicine, and he practices echocardiography in cardiac patients, diabetic patients. Basically, this conference is all about an acronym, that space, basically point of care, echo. So there is so much emphasis that we have been neglecting it. During the COVID time, we have realized the importance of quick point of care diagnosis. Patient coming to emergency room with shortness of breath, cardiac or pulmonary. We don't need any blood test, CT scan, just small ultrasound will tell us is it cardiac or a pulmonary. Patient comes with a long QT, you do an ultrasound, an echo, we tell you electromechanical window. What is the prognosis of the long QT? Can we ignore this or we need to treat this long QT? There's so much to learn from echo. When we first started in 2001, this hospital was started, our echo was mostly, the echo was mostly confined to looking for clot before doing mitral valvuloplasty. We're not even looking at anything. Only we are looking at clot is there or not. Clot is not there, patient goes to cath lab, we open the mitral valve. But from that point, it is evolved now. So much so, now with the 3D, we can do intervention. And of course, we have not done it here. Mitral clip and tricuspid valve here can be done. And some hospitals have started doing tricuspid valve private venous repair. Then TAVR, of course, we depend on the more on the CT than 3D. So basically, echo has evolved so much. All of us should be aware of what is the scope of the echo, how much it can help us, and very quick, fast diagnosis can be made at bedside. Because yesterday, the first time I have seen that, when Professor Kimura showed us some beautiful images during cardiac arrest, can tell us actually whether we should continue and we are giving epinephrine injection, where it is going. we keep giving 2, 3, 4 epinephrine, the patient not responding. So from the echo images, we realize it is lying in IVC, not going to the heart. So these are the things that how point of care echo, that quick and ultrasound will help us. And Professor Kimura is going to talk about it, and we need to learn how we can utilize this information. And lung ultrasound, I think, is the basic thing all of us should learn lung ultrasound. It's so much helpful. You can quickly decide in CCU patient, emergency patient, OPD patient. See, our on policy in this hospital is whoever walks into the cardiac OPD will do an echo. There's no information, no other history, but with the echo, then they come to the consultant. So, a lot of things sometimes we miss because we don't have any history. So we go back and repeat the echo. So echo is so much important for diagnosis, for treatment, for managing patients in CCU. Every part of the hospital in intra-op, sometimes we have to do our ventricular device closure, the apical VSDs. So how echo is helping us? We cannot give any contrast to a 5 kg child. So at that point, these echoes, how they help us in particular ventricular septal defect closure. So there is immense possibility of learning a good echo. I think I suggest all of us, we should learn more about echo. It's very simple to do, no radiation involved, and no blood test required, but quickly you can tell us so many things that we cannot get, even from history, we cannot get any information. So with that, I want to welcome you all to our space conference. So please try to learn from the experts in the field. Thank you all.
Thank you so much, sir. We have divided our academic program today into 3 sections. You can see it on the brochure also. You have an academic session 1, and then academic session 2, followed by lunch. And then we again regroup at 2 o'clock, about 1:45 to 2 o'clock, and then we start the hands-on, which have been divided into workstations, which we will be telling you later. So without much ado, we'll start off with the academic session right away. I request Vinita to introduce the first speaker.
A warm salam and good morning to everyone present here. I take this opportunity to introduce our first speaker, Dr. Bruce John Kimura, MD, FACC. Sir is a clinical professor of medicine at University of California, San Diego, and also Associate Director at Graduate Med at Scripps Mercy Internal Medicine Residency, and also Director at Non-Invasive Cardiology, Scripps Mercy Hospital. His CV runs 20 pages. The least I can tell you all is this. He is a member of American College of Physicians, a fellow of American College of Cardiology, and a member of American Society of Echocardiography. And he has been on the board of directors of Society of Ultrasound in medical education. He has been a task force member in point of care ultrasound in American Society of Echocardiography. He is one of the faculty for several international journals including JAC, CCD, JAC, AJM, HEART, AMS, and AIM. He has been invited as faculty, guest, and plenary speaker at more than 40 international symposiums and programs around the world from Japan to USA. He has more than 60 publications, peer-reviewed in leading journals like JAMA, AM Heart Journal, Critical Care Medicine, etc. He has authored 7 books and book chapters, and also importantly, he has invented the mobile app iQ, which is an iPhone application for echocardiography. I would request Dr. Barrow sir to felicitate Dr. Kimura.
It's a pleasure being here. It's an honor to be here. And we'll just get this. Okay, just a little bit about myself. Let me start by saying I'm a third generation Japanese American, born and raised in California, where I was medically trained, and I had two really important mentors in my life. One at UCSF named Dr. Kevin Chatterjee, and who actually taught me the importance of good physical examination. And then one at UCSD, in my cardiology fellowship, Tony DeMario, who taught me the value of a good echo examination. Okay, so after I finished my fellowship, I went across the street where I started to run the echo lab at Scripps Mercy Hospital, which ends up being one of the largest hospitals in San Diego County, and with one of the oldest training programs that they have in San Diego. There I met these two gentlemen, Stan Admonson and David Shaw, who were running the internal medicine program. And together, we were the first in the US to incorporate formally into the internal medicine residency a point-of-care ultrasound program in the United States. And it took us 25 years to do so. And that may seem like a long time, but let me give you a timeline of the physical examination. If we go, it starts, I have to take you way back, I have to take you before the 1700s, when disease was felt to be one of your four humors was out of whack. Or that you sinned against God, or fate was striking you down with illness. Until about 1740, when this Italian anatomist called Magagni dug up some bodies, as they used to do back then, and dissected the organs out. And he began to relate the organ appearance to the disease the patient had during life. So jaundice people had nodular livers, or cirrhosis that we know. People with dropsy, which was the term used for pedal edema, had weak hearts. So he connected the seats of disease to the organs themselves. And this book is called The Sedibus, meaning the seats of disease. So the challenge then became, well, this is fine, you're going to dig up a body and see what's wrong with it, but you need to diagnose it during life. And that's the genesis of our physical examination. So in 1754, Ornberger, who was the son of an innkeeper, would percuss his father's barrels to find out how much alcohol was left in them. And that's how percussion was developed. In 1754, some 50 years later, René Laennec in Paris rolled up a magazine, put it to his ear to listen to a woman's heart and lungs, and heard it sound better than when he put his bare ear against her chest. So that led to the invention of the stethoscope, which ended up first being a wooden tube, and then became this two-ear piece of plastic we put into our ears. Potain described Bell's with the stethoscope, and McKenzie later described the JVP. And if you look at this, remember I said it took us 25 years to put 20-year ultrasound into the internal medicine program? I thought that was a long time. This is 100 years, more than 100 years before percussion links up with JVP. So it's taken a long time to change our physical examination. And this 25 years is a drop in the bucket. So the next important thing, I think, in this timeline is Harvey Feigenbaum here in a room full of equipment, shooting the first M-mode echocardiogram. And that was in 1975. Soon afterwards, don't ever bet against technology, but the size of the machines, heart-rate machines that we see today, that's that HP 1000. And many of us have. And then in 2002, this concept of bedside ultrasound came out, laptop-sized devices that you take to the bedside and image people. But I think focus, point of care ultrasound, came up with the birth of my daughter in 2003. Here she is holding a Sathya Sai, which is arguably pumpkin size at the time. And as she got older, the devices got smaller. Here's the Siemens P10, no longer production matter, it's for production anymore. And in 2010, these came, which I gotta say, if you were in our neighborhood and if your doll was sick, she would be happy to image it for you and see what's wrong with it. Then she went to animal studies, like I said, which is started imaging her brother in 2014, and eventually got in 2018 with the butterfly and started to image patients. But then this label when he thought it was a stethoscope, because scope means to see, phone means to hear. So he really came up with an audio frequency stetophone. This is the stethoscope that he had used in 1860. That's some 300 years ago. 200 years ago, sorry, 200 years and some change. There's nothing you can talk to somebody 200 years ago in medicine anymore. And actually, he would probably talk better about the physical examination than we practice. Today we have ultrasound stethoscopes. We actually use our eyes with the scope and look at the heart and lungs. The pocket size that came out in 2007, which is about the time that the iPhone came out. They came out at $8,000 and they only had one frequency. But that's changed. Now they're on the order of $2,000 to $3,000. They hook up to the iPhone, your Android phone, and now they're even cordless with the phone connected to the transducer without having a cord to plug in. But even though technology keeps racing on and shrinking down ultrasound, this remains the technology advancing without a technique. So the key here is that you need to have a technique to act. So how would you make an ultrasound-assisted physical examination? How many sites would you choose? How many transducers? What would the purpose be? Would it be general use like our physical exam? Or would you have a different ultrasound skill in your mind? For each symptom a patient could give you, oh, doctor, I'm short of breath. Okay, I have to look at your lungs. So, doctor, I have chest pain. Oh, I'm going to look at your heart. Would it be physician-specific? Would a cardiologist do something different than an internist? Would it be screening or definitive? And we developed it as a screening technique, saying that your ultrasound, your point-of-care ultrasound was abnormal, you would get a full echocardiogram afterwards. It wouldn't be a definitive study. And so how long should this ultrasound physical go on for? The more targets you add, the longer the exam takes. And it's harder to learn, and the more chances for error and liability you have with it. So you have to weigh the number of targets against time efficiency, how hard it is to learn, its ability to be performed using basic ultrasound. So you're going to notice you get used out there. And then finally, can you do it at the bedside? So we came up with cardiovascular limited ultrasound examination to augment the bedside physical. That's spells in the mind, CLUE. So CLUE is a collection of quick little signs, just like a physical examination. They're either present or they're absent. It's evidence-based. Each of those signs has a reason why you're looking at that sign. And it has a prevalence that makes it worth looking for. And they're arranged critically. They're arranged for synthesis. It's important you do it. It's important that you do this. You do this in a certain order. So that, you guys hear me okay? Yeah. Okay. You do this in a certain order. So that it helps you with your synthesis of the differential diagnosis. And remember, this is a physical exam. It's an ultrasound physical exam, but it's formative data. It makes you create a differential. It doesn't necessarily narrow you down to one diagnosis, but to a group or organ system. Is one transducer we go CLUE based on cardiac frequency alone, and the only thing you're going to do these exams, but no real reason why we can't do this exam during a normal office visit. So this is a good summary article. This is an article of how we incorporated to the residents, the general medicine residents. And this is even an article of how quickly those residents forgot how to use it. And it turns out that in 2 years, if you don't use your ultrasound skills, you start to forget. Okay, if you want to hear this in a slightly older version, you can get on YouTube, and this was posted in 2017. You just search my name, and Cardiovascular Ultrasound Examination. And this is a talk I gave to the ACB, the Sesame, and the American Institute of Ultrasound Medicine. It's an hour long, and it goes through basically everything that we're going to go through today with a little bit of different choices. But here's the cardiovascular and the ultrasound exam. 6 sites, 6 signs. And key, you're working backwards against the flow of blood, from LV to LA to lungs to RV to IVC. And this trick is the technique to the technology. Because you already know on physical examination these signs. An S3 for LV dysfunction and S4 for LA, stiff ventricles, browse, low some percussion. You know these signs already. It's just by ultrasound, you're much more sensitive. And more importantly, if you do it in this order, you'll be understanding the physiology of how these diseases form. On the right here are the sites where you put the probe, and we'll go over those, and normal versus abnormal. So these are each of those sites. And we even have a mnemonic for each of the signs. Cardiac dysfunction, the LAE sign, ultrasound comments, effusions, and subcostal findings. So it forms the mnemonic clues. So here you have a mnemonic that takes you through your examination, which helps you know the physiology of the patient using ultrasound. That's what's different about it. So you got to label an exam. First thing you do is you take your throat and you put it in the personal axis, ICS 2 through 4, right up against that sternum. And you get aim at the right shoulder, patient's right shoulder, and you get a cross-sectional view of the heart called the personal axis, and that takes you 15 seconds just to get this information. Once you get this information, the first thing you ask is how's the LV function? And we use the each-point septal separation sign, that if the anterior leaf of the mitral valve comes within a centimeter of the septum here, it's actually kicking the septum. We call it kicking the septum. It's normal death. If it can't come within a centimeter because of tethering, because of this ventricular enlargement, tethering of the anterior leaflet, and it's greater than a centimeter, your cardiac dysfunction sign exists. And this very simple sign, which you can eyeball, you don't have to measure, you can do that in a second, has a sensitivity and specificity way better than listening for an S3 in a loud ICU or a loud ER. This is its sensitivity and specificity compared to standard echocardiography. So the cardiac dysfunction sign, look for that. Is it important to look for it? Yes, it is important. Because even we know it's important when you're symptomatic, but it's important when you're asymptomatic too. If you have asymptomatic LV dysfunction, you need to be treated. You need to be on an inhibitor, you need to be on a beta blocker, and this is all from the recent trial outcome data. Can somebody who just looks at the coincidental separation and doesn't do echo able to accurately estimate LV function? The answer is yes. So it's a simple sign that you can get on a prevalent condition. But more importantly is from the same view, the left atrium. So from the same personal one-axis view, you look at the ratio of the overlying aorta, the diameter, and the left atrium. And the left atrial enlargement sign is present when the left atrium diameter is larger than the overlying aorta. So this one here is normal. This one here, the LAE sign is present. This one here, you've already learned that the EF is normal. That's the E-point septal separation is nearly 0 there. Look at it here, it's nearly 0 here, but the left atrium is huge. So now you know 2 variables. You know whether there's LV dysfunction and whether there's left atrial enlargement. So now you have heart failure with preserved EF, or HFpEF, or heart failure with reduced EF. And the most important thing of both those heart failures, you're going to find is left atrial enlargement. Here's the sensitivity and specificity of the sign when compared to standard echo, which would be left atrial volume indexing. And here's why it's important. In a serial echocardiographic study of 52,000 referrals, As the left atrial diameter in systole goes up, we're measuring it in diastole and systole. It's larger to the aorta throughout the cardiac cycle. The diastolic LA diameter is enlarged. You're used to reporting the systolic diameter, but probably more important for heart failure is the diastolic diameter, which nobody measures. There are some people who are looking at left atrial ejection fraction when you need that diagram. But in systole, so systole enlarges, diastole also enlarges usually. You can see that if you have moderate left atrial enlargement, just this kind of modest increase in diameter for the peritoneal use, your 10-year survival is terrible, 50%. So we took advantage of this and we asked in a outcome study, does the left atrial enlargement sign help the internist to decide whether or not they need to order an echo? So in 244 outpatients who received echo, we watched their 5-year mortality, 5-year, not 10-year, 5-year mortality. And this is what it was if you had left atrial enlargement versus if you didn't have left atrial enlargement. And if you did a screening strategy where you would say, I'm only going to order an echo if I think the patient needs an echo and their left atrium is enlarged, that's going to make me order the echo. That will approve me for echo. If you do that, you will reduce your echo volume by 30%. But what about the patients that didn't order an echo on that? I thought they needed an echo. And they had a normal left atrial size. Well, it turns out no loss. They have such a minimal risk that it was probably an unnecessary echo referral. So you'll save 30% of your echo costs by using a quick look sign that you can get in 15 seconds from the peristome view. All right, so you've done that. Now you're on to looking at the atrial wall. And this is important because we're going to talk a lot about this. You take the probe, stay longitudinal, and you go into intercostal states 2 to 3 in the mid-clavicular line. Very quick. You're now at 23 seconds since you met the patient, and you're going to look at now ultrasonic comet-tail artifacts. Ultrasonic comet-tail artifacts are present here. They stretch from the pleural line all the way to the bottom of the screen. This is the normal one, where you get reverb or A-line artifact. These are A lines, these are B lines. A lines occur when the beam hits the normal pleural inflated lung and just reverberates this distance between the transducer and the pleural line, creating these big A-line reverberation artifacts. When the lung, though, is moist, when this area near the probe is moist, it gets into one of the small spaces here in purple and does a really short frequency reverberation artifact or ring down artifact and gives you a streak here. For everyone, there are 5, 10 B lines here, and we're only showing one right here. There are 10 B lines here showing this phenomenon of a ring down artifact. So we say a comet tail artifact is present when there are 3 B lines in a view. 3 linear artifacts in the one apex is specific for edema or fibrosis. That's what a real comet looks like, and that's its comet tail. 3 B lines, 3 B lines. Okay, sensitivity and specificity for clinical diagnosis of CHF, because you can't hear this with your stethoscope, and you can't see it with the chest X-ray. This is purely an ultrasound phenomenon that if there's one thing you want to learn, it's going to be if you can detect B lines. Here's how they're generated. So you can imagine it's all about the lymph system of the lung. No one really talks about the lymph system of the lung, but it's starting to gain popularity in heart failure. Here's the alveolus. Here's the capillary, where hydrostatic pressure is pushing fluid out into the interstitium, and oncotic pressure is pulling the fluid back in. But net outward fluid filtration occurs. You are leaking some fluid in your interstitium, but luckily you have a lymphatic drainage to take that off. And where does it go? Here's where the fluid goes. It goes to the CVP, right, through the thoracic and lymphatic ducts. So the problem really occurs when it can't drain through the lymph system fast enough to the accumulation of this interstitium. And the moment this interstitium gets to a critical thickness of water, it creates the B line. So the interstitial edema is what happens. You can't hear it. The chest X-ray rarely shows it. Unfortunately, If you're having trouble draining this through your lymph system because your CPP is elevated, your fluid starts to go washing out the surfactant and causing alveolar edema. You all recognize this. This patient now is dropping his O2 stat. He's short of breath. He's got to sit up and breathe. The B line for ultrasonic on comments. If you map this one and see how many comments you find, you count each B line. The B line relates to your NYHA class. It also relates to your prognosis. This all makes sense. Interstitial edema is a precursor to alveolar edema, and therefore will track its mortality. We looked at 1,000 echoes in our lab, only at the apical lung comments, and we saw that it was present 28% of the time in the lab on patients who are inpatients, and 90% on patients who are outpatients. And on the inpatients, their operative mortality, if they had any ultrasound comments or bilateral ultrasound comments, was 5 times the mortality of this echo referral alone. So these are bad to have. Let me give you a case example. This is a 50-year-old white female with a typical chest pain for a day, primarily nausea and vomiting too, but she did not show breath. And this is her chest X-ray, totally normal. She has diabetes and hypertension. So you're looking at somebody with atypical chest pain risk factors, but has no dyspnea and normal chest X-ray. This is her ultrasound right up here in the upper lobe where we place the probe. Clear, B-line, 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 going all the way down to the bottom of the screen. Then you got B-line to the bottom of the screen, but we don't know that. So this patient had severe disease, and because of diastolic dysfunction, they were starting to go to CHF from this. No better proof than to fix the lesion and to image the patient the next morning. And look what you see, completely gone, same spot. Now you have A lines, which are A for air. They clear the interstitial edema. Again, this patient had a normal chest X-ray, normal physical examination in terms of raw. This is so compelling that people are now looking at whether they can induce B lines during a stress test. And maybe the most dangerous finding you can find during an exercise stress test is if the patient runs into pulmonary edema. And you're not going to know it by asking them because everybody quits on a treadmill because they're short of breath. But this would be shortness of breath, not because they're fatigued. This would be short of breath because they're filling up their lungs with fluid. Just like a racehorse who will froth at the mouth when they're going super, super fast. Right? They'll run themselves into pulmonary edema. All right, so we did the upper lobes, and now we're going to look at the lower lobes. And this is the basal part of the lung. We put our knuckles to the bed, and we get basically a coronal view very posterior. And what does that look like? So it's now 42 seconds. And here is a normal lung base with either liver or spleen, diaphragm. And here's that pleural line shadowing what's called the curtain sign, making this all echo drop. There's nothing really over here. But look when you have an effusion. There's the diaphragm, there's the liver, here's your spine, which you can now see through the dark fluid, and that is allopathetic lung. That's what lung looks like when it's been compressed by a significant pleural effusion. That is the basilar atelectasis that everyone blows off and says, it's just a little basilar atelectasis. You're going to find that the basilar atelectasis, I feel, might be one of the worst signs that you can get doing ultrasound from lung. So we have the pleural effusion sign. Is pleural effusion a bad thing to have? This is how accurate ultrasound is compared to CT scan. So this is from Japan. And they found that if you people with this compensated cardiac heart failure, you will get some pleural effusions, tiny amounts, in 91% of patients that you'll find by ultrasound, but not by chest X-ray, not by physical exam. You'll find it by CT, but not every CHF exacerbation. It's a CT.
And choropleth by ultrasound are better than chest X-ray and or physical exam, and identifying a sleep choke exacerbation. We show you this. Here are the sensitivity and specificity of these authors on each of these findings in these patients who are normal or with compensated heart failure. Look how bad some of the sensitivities are of things we feel are super important to look for on physical or out of the chest X-ray. But look how good ultrasound is. 90 and 95% at detecting small effusions. How do the effusions form? We talked a little bit about this, that this is how fluid is made normally. It goes into the pleural space and is pumped out by lymphatics, which then go to CBP, right? The right subclavian or vein. The interstitium drains through the lung to the same mechanism, either the right lymphatic duct or the thoracic duct on the left. This is a zoom in. This is a zoom in of the surface of the lung, which normally is a sponge. Your parietal pleura is producing 250 cc's a day of pleural fluid. And it's draining through these lymphatic stoma to CBP. And the lung itself is absorbing it. It's a sponge. It's transporting fluid out of the pleural space. But what happens when you get that interstitial edema that we just talked about in the lung brain? The lung starts to leak. It starts to leak into the cavity, which then, in the setting of an elevated CBP, results in the fluid having nowhere to go. So now you get a pleural. You need to have both an elevated CBP and an elevated left atrial pressure. Both pressures have to be elevated to get pleural. If you just have chronic arterial pulmonary hypertension, you're not going to get a pleural. Interesting. You need to have, the lung needs to leak fluid in the cavity as well. Because the lung must be a very good sponge. And once you reverse that, and the lung starts to leak into the pleural cavity, it overwhelms the lung to resorb it. Okay, so if you have this, if you have an effusion with a common tail artifact, your hospital mortality is the worst. It's worse than if you knew the EF. It's so funny now because at my hospital, we always get the two views of the lung, the apex, and the two views of the lung in the face. And everyone calls that, what's the ejection fraction? What's the ejection fraction? That's the least important thing. It turns out the most important thing is that we compensated with complex core infusions. And that comes out also in terms of mortality. That combination has a 71% 5-year mortality. The patient who presents to your echo lab with this is probably not going to be around in 6 years. Here's how the Kaplan-Meier follows curves split. The green line meaning no lung findings, the red line meaning lung findings. All right, so now you looked at the lung, and now you're going to look at the right lung. We're working backwards, looking down at the right heart feels the lung pressures. It's been 58 seconds. You basically are now standing at the probe, and you're going to look at the IVC from that same view, as you know. These are standard echo views. We're not going to spend too long on the right ventricular enlargement sign. It's when the RV is larger than the LV. Here it's normal, here it's larger, and that could represent pulmonary embolism or chronic right heart failure. This is the sensitivity specificity for clinical need. And his study, he used these three characteristics. RV is larger than the LV, or when you're hypotensive or a history of left heart failure, they predicted mortality in patients with pulmonary embolism. All right, so we're working backwards. Our final stop is the CPP. Does the IVC feel the RV pressure? The IVC plus or sine curve of the IVC is as large as the aorta, it doesn't get smaller with inspiration. How much is getting smaller? 50%. These are all visual diagnoses, no measurement at all. You're getting that in a minute. So you have to be able to go look and eyeball these things. So here's normal on the left, and here's abnormal on the right. The one on the left shows respiratory variation. This is the sensitivity and specificity for elevated CPP or right atrial pressure gradient. The IDC predicted hospital readmission. So if you don't diagnose your patient enough, and they go home, they'll fill up their right atrial pressure, their CPP again, and then they won't clear their pleural fluid, they'll get short of breath. It ends up being that discharge dependent, right? Discharge dependent on this is from the University of Chicago, it's expensive group. The maximum diameter by IVC, or how much it collapsed, or its collapsibility index, all were significant in terms of predicting hospital radiation. But this is interesting. This is the cardiac output affecting the IVC diameter. Here's somebody who pays. What people forget about is that we're looking at pressure, central venous pressure. So remember Borman, if I increase cardiac output, I will decompress my preload chain. So think of it this way: if the RV doubles its output, it will suck preload dry, which will make your IVC go down at the same volume. You haven't added fluid or anything. So this is an example of this. This is a patient in clinic getting his pacer checked. Here he is paced at 70 beats per minute. And that's what his IVC looks like at 70 beats per minute. Let's just turn up his pacer to 100 and see what happens to his IVC. I'm not diuresing him. I'm not giving him, I'm doing it right now. There's nothing that's changing. So just by increasing his cardiac output, by increasing his heart rate, he sucks his preload dry. He lives now, he's dry. He did not live dry. And then what if I pace him at 40? He lives even bigger. So what if he died? This isn't him, but when you die, what does the IVC look like? Is it flat because there's nothing feeding the heart? Or is it big because it's ready to go, the dog's not decompressing? And the answer is, it's big. This is somebody who just died, and we're looking at his IVC after a code. His IVC is huge. Why is his IVC so huge? Because his heart's not decompressing. But it is intuitive. It's just something that we forget to add to the equation of central venous pressure. You can see the same phenomenon when you go on filter breathing. At peak dose, the IVC strips and get small. Okay, so let's finish up by looking at a treated heart failure patient. There's a 66-year-old with a history of COPD and CHF. I'm very short, so right. You guys already know now, EF is down, this is greater than a centimeter, and the left atrium is big, it's larger than the aorta. Within 15 seconds, you know something's possibly wrong with his heart. Working backwards, the lungs feel that high left atrial pressure. They've already got B-lines, interstitial edema, and it's wept into the lung. So now you have the pleural cavity having the lungs are weak, so you have fluid on both sides. There's a lung here with atelectasis. So that must mean the IVC is big, right? Because it was not great. Here's your atrial, your subcostal view, and here's your IVC. Plethoric and not showing much respiratory variation. 3 days of diuresis will give him. He feels great now. He's ready to go home. This doesn't change much, so don't expect EF to get that much better, and don't expect left atrium to get that much smaller. But what does change is your comets, your B-lines that were here on admission are now gone, just like that case I showed. And your pleural effusion is gone, and now all you have is a B-line right now coming in the base. Same patient, 3 days of diuresis. Your costal 4 imaging hasn't changed at all, and your IVC is less plethoric. So you decompress him, minimally improved the EF, and end up with clear lung. If you look at 754 blues admitted to the ward, these are what matters. If you look at this closely, the worst thing to have if you're just being admitted to the hospital is if you have a pleural. The second worst thing, the least worst thing, is cardiac dysfunction. It's not even significant. What's the most important thing about clues is the lung. So the fusion is the worst. The first thing that happens, regardless of what you're doing, is your left atrium gets big. There's a pressure goes up. If your left atrium cannot accommodate the pressure with dilation, it spills over into the interstitial lung. You start getting comments. If your lung can't clear those comments because your CVP is elevated, then you're going to have effusion. And then the worst thing that happens is the effusion causes atelectasis, and you lose lung territory. Start to get alveolar. So the clue exam is all connected. The cardiac dysfunction relates to left atrial enlargement. If you can't dilate your left atrium because you have a narrow atrial chest, you don't have a big enough left atrial appendage, you don't have a PFO. The fluid has to go somewhere to reflect back into the lung, causing interstitial edema. The lymphatics drain this, but if they can't drain, you can get a pleural effusion, which then causes atelectasis. The atelectasis is probably also caused by diaphragmatic dysfunction from the pleural fluid flattening the diaphragm. You end up with a hyperagitated state causing central shifting of the venous fluid to the IVC and sodium and fluid retention. And depending on your cardiac output, you can't decompress your IVC. So this is why blues is more important than just S3, S4 valves in terms of the physiology of what's happening to the patient. All right, so in summary, we talked about how quick look signs, ultrasonic distal, one transducer, and takes one. And we talked about the history of the physical exam and how 25 years is really nothing in what's happening in the physical exam. We've done a lot in this very short period of time, pocket size ultrasound. We look back on the same signs that our forefathers looked at and felt was important, but now have more sensitive ultrasound equivalents. And in the future, though, artificial intelligence, telehealth, can take this medium and do things with it that audible sound was unable to. So the physical exam 2.0, we think it's time for an update. Here's Necker Hospital, where Renee Lynette practiced with his rolled up wooden tube to listen to hearts. Here's Necker Hospital today. It's still there. They're still seeing patients here. These old walls. In fact, these trees look very similar about where they're planted. So Necker Hospital is still going. Our hospital at Scripps Mercy, 2009, Dr. Resnikoff is listening to this patient amongst all the noises in the ICU, and he's probably not hearing very much. And the resident who has been trained in ultrasound at that time knows he doesn't hear anything, is kind of smiling and saying, get out of the way, I'm going to show you what's really going on with this patient. Well, 10 years later, Dr. Resnikoff figures, hey, I'm going to be the one because I want to know what's going on with the patient. And look how happy she is, and look how sad this patient is. She can't hold the probe anymore. And that's what's so sad about the whole thing, is that in reality, the younger generation is the generation that's going to come to the next physical examination. We can start it off, but it's you guys out there that are going to come up with ideas that's going to carve the next 100 years of physical examination. And so ironically, she should be the one who's holding the probe. And that's important.
Thank you so much, Bruce, for starting off the conference. It was wonderful talk. Are there any questions from the audience? I'll start off with Sathya Sai and Balwa sir. Sir, would you like to comment on this talk? Anything that was there for the students? Everything was there, but then any salient points you want to just tell about? Yes, sir.
I can't comment about the undergraduate medical training program in the US because I don't have much idea. But definitely I know of this country because I have been trained here and my children are also getting trained in the same. I feel this shouldn't remain as an exotic technology and the tools like this is something which should be a compulsory part of the curriculum at the what we call undergraduate or MBBS level. Because what Professor Kura was talking of, which of course months later in the day when you were telling one was talking about that cardiac arrest and how he decided whether to stop or to continue the resuscitation. I have personal, of course, I didn't have any training because it's purely intuitive thing that I used to do that, and that is how I have grown with sharing. But I think as a tool, what Professor Kimura says, and now with this handheld devices coming, at least from the point of view of the, you may say it is a stethoscope extension. And in a country like ours, where we are really hard pressed for resources, this if an availability of a cheaper handheld ultrasound instrument and even just a medical graduate who is trained in that, I think lots and lots of diagnoses which normally get missed will not be missed, and even more lives will be saved. I think there is a very pertinent need that this should be a part of the undergraduate curriculum as MBBS, particularly because I agree with him that the acuteness or astuteness with which one can detect an MBBS level and detect an LBS 3 or sometimes a pleural effusion or for that matter even a lung raise, it varies from person to person. So many factors. But this, the kind of sensitivity and specificity what you mentioned, if this is included as part of the training, I think from even all third world countries, it will make a very big difference. That's what is my, I think, take home from what Professor Kimura was saying.
Absolutely, sir. I think we should just redesign this with one more echocardiography head on it.
You could have ultrasound is your
Ultrasound
mobile company is giving one add-on, that's all.
Sure, sir. Thank you so much, Bruce. We take the questions as we go along. Since we have a very packed schedule, I now request Jayashri to introduce the next speaker.
I'm here to introduce the next speaker of the day, Dr. Keshav Naik, sir, MD FSCC, FSCEI, a structural and coronary interventional cardiologist. Sir is presently Medical Director at Structural Heart Program, Silks Mercy Hospital. Sir has successfully initiated new structural program at Silks Mercy to consolidate South Bay Care in San Diego and rolled out the entire gamut of interventional cardiology program over the past 3 years. He is the recipient of prestigious National Fellowship Award to facilitate transition into the next generation of great thinkers, presidents, teachers, and national leaders. Briefly about Sir, his areas of research include artificial intelligence and medical language in STEMI, data visualization and aspiration thrombectomy, impella for STEMI, vascular access, significance of PFO in drivers and mountaineers, global cardiovascular disease, and health equity. Sir is involved in various clinical activities, including Q3 STEMI, called for CATLAB, which participates in San Diego STEMI Consortium, CCU, and Team Atomic. He is the lab preparator for high-risk PCI, structural heart interventions, and the CAT conference president and the TAB conference president. He has several honors and awards to his credit, including SCAI Emerging Leader Fellow. In addition to his professional achievements, Sir has been blessed by Swami and has been Swami student since childhood. Now I request Dr. Ayush sir to felicitate Dr. Keshav Naik sir. We welcome you, sir.
Very big honor for me. I think 1996 was our first interaction. Today I get this great pride and happiness for us.
Dr. Keshav will be speaking on point of care ultrasound for the intervention cardiologist. The hardcore intervention studies. Hello.
Good morning, everybody. Sairam, thank you very much for having me here. Thank you for the kind introduction. Dr. Iyer, I'm honored to receive your blessings today. Thank you so much. It's been really joyous for all of us to be here from the U.S. You know, Dr. Kimura actually had tickets booked in 2020. So we waited 2 extra years to come here, and I'm ecstatic that both Dr. Kimura and Dr. Veer are here with us. Dr. Krishnamurthy's brother to me, he's always going to be here every year we come. So thank you very much. I'll be speaking on focus for the interventional cardiologist. Really, we created this agenda so we give Dr. Kimura a break, so I'll talk for a few minutes because we could listen to him for the whole day. I'm blessed to share an office with Bruce. I learn from him constantly, and this presentation actually comes from just getting osmosis sitting next to him. His daily routine is he teaches flu exam to residents in our hospital, and I hear when he's teaching them everything that he just reviewed for you. So it's critically important. Even just for our hospital, where patients get admitted to the state hospital on the floor, he hears about them. He goes, Keshav, you need to cap this patient. He'll go up and do the flu exam, and right away he said, this patient's having it in mind, and nobody knows about the patient. You need to take him a break and cap up. So that's a piece that we'll review today. This is my outline. Here's the history. I just want to go over the history of medical service at Whitefield Hospital. We've been blessed to work hand in hand with all of you here. You do such incredible work. You're an inspiration to us, and I give me charge every time I come here to continue excellent care for our patients with compassion. And you do it for patients that have no access to care. So it means so much to me. We will review that. I can tell you, we flew in at 2 a.m. on Friday, and Dr. Kimura and his entire family is here. When we drove by the hospital, they all rightly gasped and said, wow, what an incredible facility. So it's awe-inspiring to be working with you. We'll talk about the case-based discussion about focus and ACS, and we'll keep it quick here and go over some conclusions and future directions. So this was us in 2019. We'll recreate this picture again with the group that's here today. I know every single member here in the picture would like to come back. They've all tried to come back this year. They weren't able to come this year, but they want to come back in the future. You know David Adams, who's next to Jay there, and then myself. That inspiration started in 2010, which was the first time we proposed to Swami in Uttarakhand. We had the good fortune of telling the Sai Baba. Is this better? A proposal to treat his patients in this hospital. We were prepared with an ASD model to show Swami how we were going to close ASDs that year. And really, we divided it so we can spend the most amount of time next to him. So I took the longest time to close the ASD right there in front of Swami. And the folks behind him were trying to push me along and say, you know how they try to push Swami ahead? And Swami said, no, he wants to see the entire ASD closure. So we took our time and we took permission to come here. We had a phenomenal experience. We performed over 80 ASD, VSD, PDA closures in a week. That was our first introduction to our team here, and inspiration to keep coming back. And I'm going to date everybody here with this picture. You'll see who's in the picture. We have Dr. Rita, ma'am, Dr.
Dr. Dodge, myself. That's when I had hair. And Dr. Barua is there, Dr. Prayag in the back, you can see Srinivas is right there, Dr. Shah, Diwakar, and all our Catholic sisters. So for me, coming back this year is a reunion. I mentioned it to Dr. Kimura, it's a reunion, so back with the family in Whitefield. So thank you for having us. And we look forward to growing our connections even more. So let me review this case for you. This is the pivotal case I want to actually involve the audience. If there are any fellows in here, I'd like your response. And it's a 65-year-old who had severe chest pain the morning of his presentation to the emergency room. He was carrying boxes at work and then suddenly had severe chest pain. When we questioned him, actually Dr. Burrow was involved, both of us evaluated him in the ER. He told us he had daily symptoms for over 6 months with exercise, reproducible with exertion. And underwent stress testing, which was negative, and was given the presumptive diagnosis of reflux disease. So but this morning was different. He was unrelenting chest pain for 45 minutes, and in his workplace, he called 911 and came to the ER. His past medical history is significant for hypertension, hyperlipidemia. He's a non-smoker, and his presumptive diagnosis of reflux disease. The paramedics on site in his work gave him measurable strength sublingual, and his pain completely resolved. But they said his EKG may have been concerning for chest elevation, although we did not capture it. They didn't capture it, they didn't grade for our review. So we see him in the ER. These are his vital signs. He's normal tensive, normal heart rate, normal respiratory rate, oxygen saturation is normal. And he tells us he's smiling. He's smiling in his earnings. He tells us, I have no chest discomfort anymore. I feel normal. I want to go home. I want to go back to my work. That's what he wanted to do. We did our physical exam. It was completely normal. And we reported that neither the ER physician nor the general cardiologist reported any JVT, murmurs, gallops, or rows. So normal exam. This was his EKG. You can hopefully look at it. There's no evidence of ST elevation or ST depression for that matter. No T wave inversion, pretty flat. ST segments, nothing abnormal there. His chest X-ray was completely normal. No abnormality there. And once again, the patient is adamant. Says, this is just my reflux. Let me go home. He's quite adamant. He was actually fighting with me and Dr. Kimura. And Dr. Kimura had his whole blue team with him. So he did a number of residents, and he come in with his bag with an ultrasound machine and ultrasound gel. And we were all very inquisitive and curious because we heard of transient ST elevation. So this is our differential diagnosis for all our trainees. We have cardiac ischemia, either unstable angina and STEMI, or transient STEMI, which is a recent entity that we're focusing more on pulmonary embolism, aortic dissection, either chest pain, non-cardiac etiology, reflux disease, or anxiety. So I wanted to poll the audience if a cardiologist fellow or resident can tell me what they would like to do. What would you do next? In summary, you have an asymptomatic 65-year-old male, normal physical exam, normal checkup. Would you do a CT angio-PT like most PRs in America do? Looking for pulmonary embolism or dissection protocol. You do a second troponin in the emergency room and triage based on the second troponin a few hours later. Do you automatically admit for observation, rule out myocardial infarction? Or you listen to your patient and you discharge your phone with the eye because he wants to go home. Says, I feel back to normal. He didn't get any therapy in the ER. He just got the nitroglycerin sublingual spray doing by the paramedics. Anyone want to render an opinion?
Anyone can take that up. He's asking you what's going to be done next. What would you do? Anybody? Any of the clinicians? So you're talking about triple rule out here, basically.
Yeah. We'd like to do number one.
It's like a triple rollout is what we use for a pulmonary embolism versus dissection versus ACs. That's what we was looking at.
Okay. So, fortunately, we had Dr. Kimura. That was not one of the options, but Dr. Kimura was there, and he had his handheld ultrasound. You know, if not for him, I may have said, let's get a stat echo. It would have taken for a long time to get a stat echo. But we had point of care ultrasound, and we found multiple B lines in 4 lung zones, as you can see here. And all 4 lung zones, you see these asterisk B lines and common tail artifacts in both bilateral upper and bilateral lower lung zones. And on the same exam, we found preserved left atrial systolic function, no wall motion abnormalities that we could ascertain, a small left atrium and normal intra-venous cava. The ER did, as you requested, a CTPE, which was entirely negative, and there were no pleural effusions. So what would you do next? Now you have the same asymptomatic male, normal CT, normal EKG, normal troponin, but an abnormal lung focus. Abnormal lung focus. So the only thing that's abnormal now, and he's not even in, usually STEMI is going to the alpha pod in high risk ER area. He's actually almost in the hallway stage. It was in the B room, the hallway, because of this triage. Would you now admit for observation? Or do a routine left heart catheterization maybe the next day, or as an outpatient? Do you do an urgent emergent left heart catheterization, or do you discharge an all PPI?
Anyone would want to take that up? Something normal going on already in the lung.
See that, the presence of the lung B line, what you're telling, you can say a surrogate marker for a diastolic dysfunction induced due to a sudden severe ischemia.
Correct. Absolutely, sir.
I think that should be the strongest tool.
Right. Oh, and that's exactly, Dr. Kimura was luckily with me, right? And we diagnosed him with flash pulmonary edema. We said this was early precursor interstitial edema because of the abnormal lungs. And I was convinced enough because of my experience with working with Dr. Kimura. I took 3 patients off the table. I had 3 more patients to the cath. I pushed them off and took him straight to the cath. And found critical left main disease, left circumflex disease, and RCA. So he had severe 3 vessel disease, and that was his presentation. And so I put a balloon pump, put him on heparin, and he went for cabbage that day. And after surgery in my clinic, B lines were completely resolved after the resuscitation. So what this case exemplifies, everything that we discussed earlier today, where focus and especially lung ultrasound completely enabled urgent triage of acute coronary syndrome. Change without that, he could have gone home, he could have gone home with critical left main disease and decompensated at night, had sudden death at night, or got up to the ward and just been waiting for a cath at some point for abnormal components or his echo and wall motion, which he didn't have. So there are life-saving implications and risk stratification of acute ischemia, use point of care ultrasound, in particular lung imaging. And in this particular case, we linked acute ischemia and interstitial edema as a possible precursor of alveolar edema. And we were able to, Dr. Kimura and I, we published this in Jack case report as asymptomatic flash pulmonary edema, like point of care ultrasound, how we impacted this patient. He continues to see me in the office now 2 years later, back to work and very active, and thankful that we intervened for him. So these are future directions. For an intervention, I was talking about echo. That doctor I showed you, Dr. Cowley, is a pediatric cardiologist, 10 years ago told me, you know what? I now let my imager do all the imaging for me, so the interventionist can just do procedures. And that's about the time the birth of the interventional imager started about 10 years ago. And now, full circle, I'm back to using my own handheld ultrasound and learning from Dr. Kimura, just like you are today, about how to incorporate incorporate that into my daily clinical care. So in this case, I would say we need further physiological elucidation for the cascade of platform. So we understand interventions, but it's in the interstitial. If I see B line, I need to be worried about that patient. Consider clinical studies of applications of lung ultrasound and ACS. And for us interventionalists, we need to promote handheld ultrasound and vascular access. I think now as a TAVR operator in the past 10 years, we're using ultrasound guided microfunction access much safer now. I would urge all of you, if we're going to teach vascular ultrasound later today, I use vascular ultrasound for even for ER function. If I can see the needle, and see the angel wall, I know I'm safe. And I teach that now. Previously, prior to doing TAVR, I would tell all my fellows, this is your ultrasound, your fingers. And I don't know how, machoistic that was for all interventions to say that your fingers are your ultrasound. But now with our own understanding of how ultrasound is showing us the vessel wall and where our needles are entering the vessel is critically important. Promote focus in the kappa for intraoperative changes, complications, pericardial effusion, tamponade, pneumothorax, what have you, past any kind of invasive procedure when doing kappa. And then further study and focus in cardiac arrest. This is a hotbed current research, and I know Dr. Triage is going to talk about that later. We had a wonderful talk about that yesterday, where ultrasound and cardiac arrest predicts survival when cardiac activity is detected acutely in emergency. So final conclusions, I hope you agree with me here, at least this case in particular exemplifies where focus can enable triage cases and have life-saving implications on this study. I would at least do my part to promote focus training for everyone in our hospital and anywhere else we interact with residents and fellows in ICU, amongst cardiology meetings and groups, ER physicians, and really to obtain image acquisition quickly and then interpret it properly and improve the results. Our day today is going to focus a lot on lung ultrasound and how to interpret B lines and make important clinical decisions. And that's it. That's our main preferences. So, thank you very much.
Thank you so much, Dr. Keshav. Very enlightening. But I'd like to make a few comments. Sunil has joined us, and Dr. Satish Govind sir has also joined us. I welcome you both, sir, part of the entire team, Sathya Sai family. I just request Gurva sir to make a few on this particular talk. So should this become a part of the usual, like critical care or a OR, ER or whatever they call it?
There is no question about it. But you have shown there is enough evidence
Yes, sir.
already, and I think it should be a part and parcel of every patient coming to casualty with dyspnea or chest pain. It should be routinely done. But I am surprised at I don't know how long it will take for all our MBBS all over the country to learn this, because they are going to practice in remote places, villages. There will be no chest X-rays, right? And they have to come to the city to get the X-ray. This is so much, cost-effective and fast way to make a diagnosis. So I think we should send a request to Government of India that it should be made compulsory for all MBBS in the country, especially in India. We may not require as much in the US, but we definitely are saying need for this. Because how you save that patient?
Exactly.
Simple.
I was just going to ask that because this is, I think, everyday patient that we see in the emergency. Someone with almost normal LV, isn't it?
Yeah,
Probably negative,
yeah, they send home.
we would have sent home.
And it's very simple. It's just you need to have that patience and time even me as an interventional cardiologist, you're so busy and then you have to pull out the ultrasound, fire it up into your phone, and then pull out ultrasound gel. You have to get over that inertia. Dr. Kimura is in our practice, in our group as well, we have 10 cardiologists. Only 3 of us have our own ultrasound probes. Despite all the wealth of data that Dr. Kimura has shown and proven to us, we have to get over that and believe in getting that information, seeing it with your own eyes and wait a second, this patient has lungs, it's something different that we're not appreciating. And use early invasive management rather than put the patient on the floor and then they have quick blue arrest in the middle of the night.
We'd say this, like, yeah, if you see, when I saw the lesion,
I would have arrested that.
I arrested any given one.
So that happens on a daily basis with our team, where we hear, well, that not everything is matching well here. We need to, what did the focus show? When it comes up to the question, it's very important. So I hope you adopt that in your practice. Sure.
Thank you so much, Keshav. In 2019, it was the big C was malignancy or cancer. Of course, everything changed that. The C is something different now. And to talk about that C and the lung imaging in C. The lung imaging in C, it's going to be Dr. Bruce. Yeah, Dr. Bruce will be enlightening us about lung imaging in COVID-19 cases.
So what is a cardiologist like myself and echocardiographer talking about COVID for a while? So first of all, this is impacting all of us, the whole world. And it turns out if you have an ultrasound machine, you can make an impact. Whether you're a cardiologist, an OBGYN, anybody with an ultrasound machine can make an impact. I want to show you why. So here is a typical case in COVID. And I'm going to go through it through the framework that we just learned called the clue exam. First thing you do, remember, first 15 seconds, you get your parasternal lung axis. And it's kind of hard to see here, but the EF is normal. Left atrium is generous here. It's just a little bit generous. So working backwards, there's a little bit of diastolic dysfunction. And then, of course, tons of comments. But no pleural effusions. And finally, you get to the subcostal views, and you have an IVC that's slightly dilated. So this is a patient who's been intubated, and because of that, they got some fluid and ended up a little bit moist. But the most important thing to notice here is that the comments are existing without pleural effusions, despite having a high CVP. And so what we learned from before, this is probably pure interstitial disease. Because if it were CHF, 91% of the time, the Japanese data would say, where's the pleural fluid? If you have elevated central venous pressures, elevated left atrial pressures, and the lung has comments, it will soon be fluid that you're not going to be able to drain. So the fact that there isn't any here makes you wonder if this is an interstitial pneumonitis causing this edema, not hydrostatic pressure. All right, so what is known? This is mainly from the initial Italian and China observations. They explain this is a normal 2 rib shadows, pleural line. This is all the A line we talked about. And they describe what were called these huge beams that came down off a very raggedy pleural line. And they call those beams, or those B lines that have coalesced, light beams or waterfall. And they related them to ground glass on CT. And they noted that there were skip areas, not just due to rib shadows, but there were areas that was very patchy where you got these waterfalls or highlights, light beams. The pleural line, they noted sometimes, was inflamed and puckered, and at other times it was smooth, like in early edematous states, like in CHF. CHF is always smooth. ARDS is always flat. It tended to happen more in the lower lobes when you look at CT, and pleural effusion was rare. In our COVID cases, here's a light beam in the upper lobes. Here's a light beam with a smooth pleural line. Here's a light beam with an inflamed, this is a light beam with an inflamed pleural line. Look how raggedy that pleural line is. Look how smooth that is. So what is the difference between this sawtooth, raggedy pleural line and this nice, smooth pleural line? And it's probably related to inflammation. So pure edema, smooth line, it's more compliant, the lung is more compliant than what we were describing as L-type respiratory failure in COVID. In the inflammatory part, where you get ARDS, it was thick, bright V lines, a rough pleural line, and a very stiff one, or H-type. And in between, with COVID, we kind of had early edema and eventually late fibrosis running the show. So you could catch COVID in any one of these states where they had the V lines, but the pleural line was evolving depending on whether that inflammation was going on. And that could take up to weeks to figure out. So here's somebody's chest x-ray, horrible chest x-ray. That's their initial upper lobe V lines coalesced on admission. And here it is 1 month later. 1 month later, there's still V lines. And look how rugged that pleural line became compared to how smooth it was on admission. Chest x-ray still looks terrible. The Brazilian data said 73% of people had V lines. 73% of people who were inpatients had V lines. From New Delhi, 40%. These are people not admitted, but in the emergency room. 40% of those patients had greater than 3 V lines. And 35 to 30, 33 to 37% were in the upper lobes. So that argues a little bit against congestive heart failure because it would have to involve the entire lung. It would be the flash interstitial edema that Dr. Nayak spoke about. And that's gravitational. It's worse off if you have it up at the apex and more common to have gravitational edema in the base, just like Raoul's. So 37% in the upper lobe. We decided to look at our experience with 160 patients that were inpatient with COVID-19. Just the 2 apical lung views of that you've learned today. And here's an example of what we saw. And here's the breakdown. This is the percent possible of V lines in those upper lobes. And here's the disease severity. So we broke it down by disease severity. So if you were critical COVID, there was an 82.6% chance you'd have V lines, with a 60%, 61% chance that you would die. Conversely, if you happen to be in the hospital for a broken leg and you happen to test positive for COVID at the time, 26% you still have V lines. Even though you were there for a doc, I'm here for a broken leg, what do you mean I have V lines? 26% have V lines, and there was a 3% chance you would die. So this is how it works out. V lines course with mortality, and the prevalence gets very, very high, but it's substantial even if you have no symptoms. And interestingly, mild and moderate means your O2 sat is normal. So you could have a set of patients, significant set of patients who don't have hypoxemia and who have V lines. Again, the interstitium is involved, but the alveoli are still functioning. And then there was this doctor, Gali Chen in Madrid, who says, hey, I'm out, I got COVID when it hit Spain. I have an ultrasound device. I'm going to image myself every day just to see what happens. And unfortunately, or he knew from the CT data that I'm going to look at the base of my lung because that's where it's more common. And he looked at the base of his lung, and day by day he described what he got, which eventually were comments. And he said, after day 3, V lines and a thickened pleural line started to form, but no dyspnea and a normal O2 sat. These again are forming just like an ischemia when a patient is looking at you. Fine, I'm fine. Can I go home? What do you mean I have V lines? What do those mean anyway? And he said he could predict his symptoms worsening with ultrasound before he could have it. Now, we knew that getting your hand behind your back like that is a young woman's ability. It's not the older person who can do that. So we asked the question, well, let's use the apical views that are part of CLU. They're easy to do. You don't have to undress. You can just pull your shirt over and look at your upper lungs. That would be nice, right? And we came up with a form that would teach the patient to do that, because the patient is in isolation. And they would put gel here, they dip the probe there, and we told them this is where we put it. And when we did that, we looked at 80 patients initially, 40 cardiac patients admitted, 20 patients who were actually admitted for COVID, and 20 patients who had dyspnea, unexplained dyspnea. 88% of patients could do it, who are under 80 years of age, with an 88% accuracy. So it was clearly feasible that a patient could image their apical lung, as long as they were fairly young. Well, so this led us to thinking. In COVID-19, there's tons of inpatient studies, I've shown you 3 of them, that have demonstrated that B-lines relate to disease severity and mortality, and it can occur in the apical regions that could be imaged by the patients themselves from isolation. So we sought to determine the prevalence of B-lines in the early outpatient infection and then test the accuracy of patient self-diagnosis. So I read this and I say, how does a cardiologist end up in this field? It was interesting. We felt it was our duty. We had an ultrasound machine. People were dying. We needed to figure out what can we do with our ultrasound machine. And this is what we found. This is going to be published this month. It's already available online. Within 1 week of symptoms, while lacking fever or hypoxemia, 27%, just like our prior study of inpatients, of 201 outpatients had 3 B-lines in their lungs, and 8% had bilateral B-lines. Patient telehealth and automated methods demonstrated like a 90% accuracy. So this was a big deal. This was a big deal to say that 27% of people who look great, who say, oh, I have a little, I feel great, I have aches in the back, or I have a little cold. They don't, their stats are fine. This is a lot of patients. And they could image themselves with telehealth or at home with a significant accuracy from isolation. Think of all the people you know who tested COVID positive. They should have been able to look at their lungs and tell you if they're going to get worse before they got worse. So here's a schematic of how the study laid out. We had 200 patients who had 1 risk factor and mild to moderate disease, in other words, no hypoxemia, less than 10 days of symptoms, they just tested positive. They were coming in to get their monoclonal antibody, and so we just imaged them. We imaged them while they were getting their monoclonal antibody. And looked for comments, and that's when we found that 25%, 27% abnormality. And they had the one that wasn't normal, had a normal oxygen sat and a normal temperature. He looked just, or she looked exactly like all the others. There's no way you could tell that the patient had comments in their upper lobes. And think about it. If they had comments in their upper lobes, how did they get them? They had some sort of immune response in their upper lobes. And one of the hypotheses we came up with is they self-infected, they self-inoculated themselves. Because we know the disease gets and starts in the nose, right? And that's why we wear masks. We're breathing it on other people. And they get it in their nose, and then they breathe it on other people. But with every breath you take in, you're breathing it into your own lungs. So some people are going to self-inoculate, and it's going to spread to their lungs. And if their lungs have a very violent immune reaction, especially to Delta and the earlier forms, you can get this huge IL-6 cytokine storm, and that's what kills you. But the first step in that cascade is it gets involved your lung while you're feeling okay. So that's it's important to detect this sign as sort of a canary in the mine, that if you get this, you have to watch out. So 25%, it raised your risk for hospitalization 10 times, and that usually occurred 5 days after you tested. These were people who got the monoclonal antibody. And now as a subset, we took 50 patients of those original 200. Some of them sat there, instead of the doctor doing it, they imaged themselves, they sent it via telehealth to a doctor somewhere else who then diagnosed it. And that looked like this. Here's a patient imaging herself, holding up the camera, holding up the phone to an iPad, hooked via FaceTime to a doctor here who's in the hospital at this moment. And that doctor is deciding whether or not she has comments. There's another view, somebody with comments, showing that from the camera's point of view, that you can diagnose. That's how the telehealth arm is done. But also, besides the telehealth arm, we did the artificial intelligence, because a lot of devices, as devices we use today, have automated detection of B-lines. So maybe the patient just tells you, doc, I have 3 B-lines, the phone told me. And so here are 3 B-lines that it's detecting. Without even seeing it. This is just the device detecting it for them. And both of those had about 80 to 90% accuracy. The human, the physician doing it is the best. But because you can search for B-lines. The patient and the AI don't know what the B-lines are. They're just putting it on the spot and telling them to put it. So the ultrasound finding of B-line was prevalent, 30%. It's prognostic. It relates to death, actually, and hospitalization. And you can diagnose it remotely. So we can do this today. And in your echo, if someone comes in COVID positive or has a fever or shortness, doesn't even need a fever. Remember, there's no fever, no hypoxemia. They're getting an echo and they have comments you can't explain. COVID is in that differential. And the air that they're breathing out through their nose is filling the echo valve, which always kind of freaks us out because they get that negative. And they're breathing out COVID. Who are these people? Well, they tend to be older. This is the patient characteristics of people who are ultrasound positive versus ultrasound negative of the 200. And this is the p-value of their odds ratio. But these are the important univariate predictors of having B-lines. And just like we know, it's going to be the older patient, the male patient, the diabetic patient, the hypertensive patient, they all ended up being significant. So this is a typical data set. And vaccine status was significant. In fact, whether you were vaccinated or unvaccinated, being unvaccinated doubled your chance of having comments. And then it was significant if you were the number of people who were related. Here's the actual data of the 5 people who were admitted. I know that's a small number, but it tends to be really small numbers once you get the monoclonal antibody, because it really prevents the disease from killing you. And many of these people were vaccinated and got the monoclonal antibody. So the chances of them progressing to severe disease is very low. So here are the patients, their ages, whether they're finding whether it was bilateral, whether they were vaccinated or not, and how many days they were symptomatic before we imaged them, and how many days before they were admitted. And here's their weight and some notes. So patient number 1, 40-year-old strong, 40-year-old, I remember this guy, 40-year-old strong guy. He was a little bit big guy. He was vaccinated though. He had bilateral findings. Here he is. Actually, this should say vaccine positive. I'm sorry. Patient was vaccine positive, and he was admitted that night. After we gave it to him, he went home and he said, "I can't take it anymore. I'm going in," and he was just admitted. Here's an example of somebody who was he was unvaccinated, and he immediately got admitted. The vaccinated person, patient 3, it's interesting, the 2 vaccinated people took a while before they got admitted. It's as if the vaccine, they were fighting a good battle as an outpatient. The people who are unvaccinated got admitted fairly quickly because they had no defenses. But the vaccinated fought quite some battle before they got admitted. So the vaccine we felt was working, not only in preventing disease, but preventing hospitalizations. And that matches the data that we have. Both teleguidance and artificial intelligence had lesser sensitivity than the physician. We talked a little bit about that. You're better than the automated ways of doing this. But of course, that means you have to go into isolate. You have to go into the patient's isolation bubble and image them with either PPE on or some way to protect yourself. So there's a reason why telehealth and artificial intelligence will help out in COVID with about 90% accuracy. And this is the bottom line. Why would we do this? Well, at day 0, you're in an upper respiratory infection. The virus is in your nose and in your throat. Maybe you start to so let's say there are 200 people who have it in their nose or throat. They feel like they have a sore throat. They might self-inoculate. They might breathe it into their lungs. Maybe their vaccine is waning. Maybe they got a huge viral load. They're in isolation, but despite that, 50 of those people, 25%, will get B lines. 50 of them. And those 50, that usually happens at day 5. It's silent. They don't know what's happening. They don't know their oxygen is still normal. Their chest X-ray is still normal. They don't even have a fever. So why don't they just get admitted? Because the vaccine protects them a little. Omicron is less virulent than Delta was. And for some reason, cardiovascular risks increases the chance they're going to get a systemic response. The systemic response, we don't really know, but we do know that hospitalization happens at about 10% of the people who have lung pneumonia. And that's the systemic response works through, who knows why some of these factors cause this huge cytokine storm for which we can know it's mediated and can be mitigated perhaps by steroids when it's really bad. And that happens around day 10, and by then you're O2 stat, and your full inflammatory responses happen. And of those 200, one of them is going to die. But 50 of them, if you use ultrasound, would have been identified and appropriately isolated. So does that make a big deal? Well, it does. What if these are children at the school? Would it be nice to know which classes? Is there a child in there who has comments who's spreading COVID around? What if it's a classroom? What if it's your college? Who needs to wear a mask? And more importantly, this line is drawn where you can intervene. And perhaps point-of-care ultrasound can determine, certainly these 50, we can argue, are worthy, regardless of their age and presence of risk factors. The presence of a B line probably should qualify them to get monoclonal antibodies or antivirals to prevent a severe systemic response, rather than just using a risk factor alone. All right, so thank you for your attention. This says, when this is all over, what should change? And she says, everything. And which is so true. We have so many things we can do, yes, but at least for this group, if you have an ultrasound lab, an echo lab, you can certainly look for comments such as 2 Ps may have heard lows. 25% of people who are infected will show that. And that person needs to be addressed before they leave the hospital. Okay, thank you.
We have quite a few critical care specialists who've been here and have treated COVID patients. Does anybody have, all of you have treated them. So does anybody have any questions on these? I even request Satish sir and Sunil to join in. Do you have any questions on anything that feels that? Anyone? Yeah, do you have a question there? You have a question from the audience as well? Yeah, please go on. We'll have the technical comments now.
When is the best time to perform both the screen?
Yes, so the question was, when's the best time to screen, which is a great question, right? Because you don't know when the patient, you don't even know if the patient has tested positive yet. So I'm thinking probably around 5 to 7 days after exposure is when you're going to start getting a positive. When you look at the people who were admitted that we saw were positive, we got them around 7 days from the start of whatever symptom they thought. It's really, really hard to determine time from exposure. Like if somebody gets sick, and heaven forbid, that didn't happen, but if someone gets sick in a group, is this the day of exposure? I mean, you have to look back, well, who was I with 3 days ago? I don't know. So it's really hard to know the time of exposure, but from the time of symptoms, probably 5 to 7 days from the time of symptoms. So it brings up a big question. You get a device, you say, well, you're negative, come back tomorrow. And we'll look again. Come back to the next page. When are you over the hump? No one knows. I'm guessing if in the first 5 days that you're in isolation, you should probably image yourself, if you could. If you could.
Like, how far does it correlate to the saturation all the time?
I'm sorry?
Oxygen saturation,
Yes.
how far does it correlate to the ultrasound examination?
Yes, so the ultrasound examination, it's specific. In other words, once your oxygenation starts to fall, you almost certainly have comments at that point. But there's this huge phase where the oxygen saturation is normal, and you have comments. And that's the key phase, because that's when you want the antiviral. You want to get the patient away from the other kids, away from the other colleagues, and put them in isolation and treat them. And that's probably, as a public health method, important.
Thank you. Just suggest
Yes.
a general comment, it's just an observation for wonderful presentation and nice patients and issues. I think it's more from the Indian context of
Right,
how
right.
we have, really sort of like. In terms of the focus on ultrasound, I think the perception from there are 2 weeks. One is the penetration of the handheld has really not happened, and it's still because of so many reasons. And secondly, the acceptance of using this with the cardiology community is very limited. It's still perceived as something which is more of an intensivist or a triage person or even the radiologist. So I think that's because of the lack of transfer of knowledge and unsure of how to do it, and maybe the ultrasound probe itself. So I mean, it's just making a general comment as to how it is still not really risen to the level where it's being done and it should be used.
I think that's the whole point, which actually why we have the conference. We wanted to popularize the use of that. That's what actually Dr. Bruce was telling us yesterday. It should probably reach much more than what it is reaching right now. I think I really wanted expert comment from IS sir. Oman, he's been in that thick of things from 2020 to 2022. Someone who ran the COVID ward in a place where there was nothing for the next 200 kilometers. That is Pudavati. So, sir, you have to share your experience with how you think this.
What sir told about the handheld, one of the factors is the cost. In a country like ours, between investment and usage, if you say institutionals from the governmental, they're okay, then maybe they put it. They see the output, what is the question of revenue? Private, same thing. So that is one of the major factors preventing its penetration in this country, I think, is the cost.
I think so. With TAVR coming in and CRT happening cheaper, I think this will also become. I think it's a time that we should use it to make it more cheaper. That's one thing.
Yes, it is. Sir, you are talking of this. I still ask, why should you have in a country like India a plain, simple 12-lead ECG machine costing 1.5 to 2 lakhs? Who wants a computer-interpreted ECG? Day in and day out, you get referrals to a hospital. You will be getting, I am getting there. 8 out of 10 referrals, acute anteroseptal MI, sense, because the computer is interpreted. And you see the ECG and say it's nonsense. So, just for making it enabled as a computer-interpreted ECG, you end up talking of so much money. See, I am talking of country like I am maybe too much worried about my country. I want something which has to go to the grassroots level.
Right.
Whether it is with the EKG machine or whether it's a handheld ultrasound or Doppler, it should be something which should be affordable. That is what which brings the penetration. Then comes the next question of whether it should be a part of an undergraduate curriculum, which I feel strong. How much is practically feasible, that I don't know, because on that I don't have control. But yes, it needs to.
Right.
It's a very good idea.
Sir, coming to COVID, how do you think? Because you run the COVID ward there. How do you feel that this?
Sir, COVID, what? I of course was in absolutely rural area. And the problem was, either you had to use somewhere around 50 or 75 lakh ultrasound, your echo patient to be shifted to the COVID. If it is shifted to the COVID, then you cannot use it for your patients. I am talking these are practical considerations. or try to get an ultrasound machine and try to use that just to get bare minimum kind of test. That is one. Two, X-rays. Three, we had what we call the first wave, the second wave. The behavior of the patients, particularly the ones who deteriorated, was really totally different. There was this patient, 4 days, 5 days is fine. We almost come to the point that you are fit and then we can go home and it drops. 5th day, 6th day, the saturation drops to 30. This was one pattern. Now, we had no predictability other than daily 3 times a day see your saturation, we had no predictability. And in fact, patient is getting, sir, I am fine, what is the problem? My saturation, okay, and then this drop. As opposed to the other group, which got sick, matter of hours,
Crashed.
they crashed. You just stood helplessly watching them. Could do nothing, to even intubated them, put on ventilator, saturation went down. Now, and that scenario, yes, if as Professor Kimura said that when you have such a kind of mass number of patients, if you could use this definitely as a triaging tool as to which need to
Triage,
hospitalized
triage,
care,
triage.
care, what's the one which can be isolated.
Yes.
There it has got a wonderful goal. Moreover,
I think that really puts it in perspective.
number two, about again the use of steroids and maybe the use of drugs like remdesivir and all. As you said that in many cases before the hypoxemia set in, you could see the cocktails. If you could start, maybe more number of cases could have been salvaged. This is an hindsight now. But from looking at it, it looks like that. That's my take on it.
Yes, sir. Thank you so much.
I agree with those comments. I think in terms of getting the cardiologist involved, the way we ended up doing it at our hospital is if you start it in the hospital, if you start the revolution in the hospital, you can put those 4 views into your echo. So our echo lab, every echo done gets 2 views of the apex and 2 in the basis. And the sonographers learn that very quickly. It's not like the continuity equation, right? There's no measurements. They just have to know where they're putting the probe. And we already went over a session and a lot of the sonographers here quickly pick it up. It's so fast that once that occurs, the readers start to understand, wait, this is new data. Oh, I'm getting to correlate it with the E prime ratio or some other ratio that I understand. And then you have a wonderful, powerful tool because you've already invested in the machine. So you don't have to go buy a machine, but very quickly after you have that embedded in your mind that, hey, this is a surrogate that I can do that doesn't need tissue Doppler or strain imaging. I can do this by looking at the lung, and it has diagnostic data. Then the cardiologist says, I think I'm gonna buy it because I need this in my office or at an outreach clinic. And then it becomes an interesting question: is it worth it? I also own an old echo machine. Why don't I just move my old echo machine to the clinic? And those are financial questions. For COVID, it is tricky. It makes you wonder, right? If we just did, you get. So the 2 I've talked about is left atrial margin determining whether you get an echo or not, and B lines to determine if you get Paxlovid or monoclonal antibody or not. There's going to be tons of savings of monies that would actually afford a $3,000 butterfly or whatever device you want to get to centers, community centers, wherever you want to put that. I don't know the economics and the public health implications of doing that, especially in India. But these concerns are exciting because now you have something on the health side that can help you protect and manage your resources, of which you already have the resources paid for, at least in the hospital already. And maybe that's just the start. 5 years later, this ultrasound stethoscope becomes a reality for students and doctors.
Excellent, Bruce. As you get ready for your next talk, right? Yeah, sure, sir. Sorry, sir.
Before I had one question. As Dr. Iyer was saying, the feasibility of using focus in immediate patient was limited. So what we did was during the Delta wave, we tried to manage the patients on anticonception. We just wanted to know in your study whether there was any correlation with the inflammatory markers and the B lines. Any data was there between the inflammatory markers and the CRP, ferritin, D-dimer. What we did in Delta wave is in India, we did not follow the focus type. So we used to manage the patients by following up with their all these inflammatory markers and see how they are working. And depending on that, we suggested attrition and obviously the saturation and all. Was there any correlation?
Yeah, I think, I can't remember the group, but yes, there's a group that has done that, but very small numbers. And it gets very interesting because the people that were prone and whatnot seem to get better, and that's those people, their B lines, I'm presuming, are shifting depending on the fluid. You know, they have this leaky capillary bed that if you get in your bases, because most people, the posterior base on CT is involved more because most people are probably lying down or sitting down of their illness. So the gravity itself pulls those B lines down there. But it gets to a point where you get enough B lines that you have to sort of prone the patient, position the patient so that the B lines get out of the way, gravity pulls them away so that you can aerate that particular amount. And I think it all ties together with inappropriate ARDS like capillary leak that's caused by the interleukins and the cytokine storm that's responsive to supine mutation that causes ground glass on the CT scan and B lines in weird positions that you'd never expect, like the apices. We like the apices because I think it is inflammatory in the apices. Because I can't explain why 27% of people with mild disease would have it in their apices. Because gravity, if anything, is going to pull it down to their bases. But it showed up in their apices. So that must be a signal that there's something going on in the interstitium in the upper lung that probably relates to inflammatory markers IL-6. But we don't have that data. It's a great question, great research question. We thought that it turns out that the upper lung has the worst lymphatic drainage of all the lobes of the lung. It has the highest oxygen saturation, and therefore the highest free radicals of oxygen exist. So there's probably, we thought there was more damage, immunologic damage potential. And then the final thing is the inhalational diseases tend to go to the upper lobes, right? Like silicosis, brucellosis. All the pneumoconioses go to the upper lobes. And this is an inhalational disease. And so it goes to the upper lobes and probably resides there, causing some local inflammation, giving you the comments. Is what we're thinking. But it should relate to IL-6, I agree. Thank you.
Thank you, Bruce. As we get ready for the last question, for the last talk of this academic session, a very, very quick comment. I know you have been a part of the COVID team in Whitefield. How did you find focus? You used focus in Whitefield. So how do you feel it worked?
I was in the ICU, I'm a cardiac anesthetist. Given in the ICU for the COVID, one thing that COVID taught us was we were using ultrasound, we use the sonocyte machine. So vascular access, wearing PPE is very difficult, you can't feel with double triple gloves. So we were, as now we train all our residents every month to use ultrasound for all our clients and everything. So they, just as a preparation for anything which comes ahead, ultrasound, we use it for all of vascular access one. Second thing, we use it in just not for COVID. We also use it in a CT-based ICU, using lung water, seeing the amount of water which is there in the lungs. It's really helpful because we do not need an access. Before we extubate patients, we do it to see this patient needs, even if you have prepared the patient or not, this patient needs a diuretic before you extubate the patient. Third, during COVID, what we were finding is we were finding lung water, but the BP, we were putting lines, the lungs were filled with water, and the BP was low. So to start an inotrope, just not giving volume to increase the BP. But the choice of the inotrope, like maybe starting noradrenaline, really helped us. Apart from making sepsis, the patient was vasodilated with a lot of water. So we used it that way. And we could not shift patients down repeatedly, so we were checking how bad the patients were, depending on the score of water. That's how we used it. but definitely ultrasound.
So you mean to say it was both a risk prognosticator as well as on a temporal basis you were found?
Yeah, and you need to get trained because you do not know what is the next wave to come. So definitely
Great.
ultrasound is.
Yeah, thanks, Dr. Arno. Without much ado, we'll go to the last segment of this academic session where Bruce will be actually showing you on the patient how an ultrasound is done. Can I have the lights down so that he can?
Is the bottleneck.
Can everyone hear please?
Yes? Okay. Okay, so this is an unknown. This is an unknown that we're just gonna do. We're gonna try to do this like you guys are my blue team. We're just gonna do a quick exam, and it's very fast at first. So we're gonna find out how much you guys remember from the first lecture on the clue. So we're gonna try to get this done in a minute, and we're gonna figure out what this patient has. Then we're gonna go through each of you at the regular pace so we can teach, okay? So the clinical exam, this is my periscope. I'm gonna start off the periscope line. Okay. Like a Wizard of Oz where I'm hiding behind here. This is this is your standard device. It's not a pocket size, but you can do it on any cardiac transducer. It turns out though, the older devices that don't have all the good artifact suppression protocol in it, the older devices are better. So it's funny, the older devices see comments better because basically comments be like the artifacts. And the new machines have been built to suppress artifacts with second harmonic imaging, all these other things. Okay, so you guys ready? Here we go. So I take a dollop of gel, and to be fast, and you know, the gel you put on is the gel you wipe off. Because it's not going to evaporate. Slowly it will. So unlike echocardiography, I don't put a huge amount of gel on my transducer. I just put a little dollop of gel somewhere out of the way. It's usually up in the supracorticular area or down here where I'm not going to drag the cord. It's like being a painter. I put a dollop down, and then I put this away because I don't want to have to wipe it down after I see the patient. So that's all. I'm sure that's all I'm going to get to use. That's all I'm going to wipe off too. Okay, so when I dip it in there, you can see, there, get it done. So now, I'm going to start the clock, and boom, I'm looking for the paracetamol axis. I got it here. So what do you guys see? I'm not going to say anything. You guys look at it. You got your, we're going to do it in a minute. Okay, boom, it's done. And then I'm looking here. Okay. Then I'm looking here. We're looking against the flow of blood. Okay. And then I'm going to the lung left lower lobe. Okay. Okay. And then he takes a breath in it. Okay, that's good. And then the other side. There it is. There. Just a little bit. And okay, that's a good shot. And here. Okay, let's do this a little bit. All right, and then I look at this. All right, done. All right, so let's go through what's going on. One finding, name one finding. Ejection fraction, the first C was what? Low. Second sign, back, does the left atrium? You were recording the whole time. Oh, the ceiling. Okay. So left atrium, was it big or small? So that LVEP, the left ventricular pressure, was high. So what's happening to the left atrium? It's trying to get as big as it can. It's trying to accommodate the pressure. And it's trying to expand primarily in the AP diameter. And we know AP diameter dilation, as you can see here. Yeah, oh, okay, wait a minute. So the AP diameter, in other words, this diameter is predictive of atrial fibrillation, more so. So what if he had a pectus? What if he had right ventricular enlargement? What if he had a huge aortic root? The left atrium would have no ability to expand in the AP diaphragm. It would have to elongate. It would elongate, okay? And so it would still get big, but it would be forced to elongate. Where's the other place the left atrium can dilate? You get 3 to 4 cc's by dilating your appendage. And that's what the appendage is supposed to do, right? It's supposed to accept 1 cc, 2 cc, 3 cc, and then release ANP to make you pee out that extra volume. It's just like a little sensor that you had added onto your left atrium. And then finally, what if you had a PFO? Well, you squirted a couple cc's through the PFO once your left atrium got big, right? So these are the mechanisms that are happening on the left atrium to account for the LV dysfunction, whether it's systolic or diastolic. It's trying to accommodate that. So think about this. If your RV output gives you, what's the RV stroke volume? Let's just say the RV stroke volume is, let's say the LV stroke volume. Let's say the LV stroke volume is 70 cc's. A left ventricle with each beat squirts out 70 cc's. Let's say in a perfect world, what is the RV stroke volume? 70 cc's, right? It has to be the same. What if the RV stroke volume was 71 cc's? Where does that 1 cc go? What, and that's in 1 beat. In 80 beats, if it outperforms the LV by 1 cc, in 80 beats, in other words, 1 minute, that would be 80 cc's. Where does it go? In that 1 minute. What if it outperformed the LV by 1 cc only for an hour? That's 4.8 liters. Where does it go? It has to fill the lung. Because you've blown your left atrium as big as you can. You dilated your left atrial appendage as big as you can. If you had a PFO, you're pushing blood and losing a little leak through that PFO. After that, you're starting to fill your interstitium of your lung. And you're getting comments. How much can the interstitium of the lung hold? 200, 300 cc's, they think, before you wash out. Remember the alveoli. Like Keshav said, interstitial edema then becomes alveolar edema. Your lung is starting to weaken the pleural cavity, and you're starting to get pleural fluid. So that's what's happening. So given that his left atrium is big, here's a really cool slide that I like. See this right here? This, I'm guessing, is a side lobe of the RAR, right atrium, right ventricle. Let's see if that's true. There it is. So you can make a common mistake and think that that line is just going to finish. But there's all these bright lines you can see when I tilt off the parasternal axis that bisect your left atrium. There are side lobes from other views like that one right across the middle there. And a sonographer can make a mistake of choosing that line for their M lobe. That's a bad mistake. Clearly his left atrium is big and his LV is down. So you knew that. So next step. Is the interstitium, did the left atrium dilate enough to accept the extra volume of that RV that is outperforming your LV? Did it dilate enough? The answer is no, because it backed up into its lung. You filled up the left atrial appendage. The PFO didn't press as much as you could. AP diameter as big as you can dilate. You elongated as much as you could. Now you're filling up the lung. And you have 200 cc's or 200 beats that you can allow the RV to get outperform your LV before you wash out your LV so in the So that's sort of the number. The numbers are, this is what's happening. So how do you prevent your RV from performing so well? Well, you give it TR. You could diurese, right? Because the RV really likes pretty low. If you want the RV not to produce 71, but to produce 70, you diurese the patient, which is what we do. And so in this patient, We'll get to that point, but here we are with a low EF and a big left atrium, and that side lobe artifact is the left atrium, you can see it there. But he's used up his compensatory mechanisms here because he has some B lines, really faint ones though. They're not really super big. And the lower you go, the more perhaps, the lower on his chest you go, just like Rob, perhaps the more you can see. But they're there. Okay, so you have B lines, interstitial edema on both sides, right? You saw on both sides, there's a couple there. One of the biggest B lines. There's a B line. See that? All the way to the bottom of the screen. So you need 3 of those to call it a comment. And I would argue if I search hard enough, there's some comments here, but it's not as obvious as the one other there. It's not as obvious as the one I've shown you, so it's kind of resolving. Interestingly, I thought when you got me to there, I thought, okay, he's going to have pleural effusions, right? But when you got down to the base, he has a good kidney, so he should pee out whatever Lasix you give him, unless it's an acute renal failure. And then you have comments in the bases, you can see them there, but there's no pleural fluid. No pleural fluid. So he just has interstitial fluid on that side, and on the right side, we really like to get pleural fluid. He has a good kidney, and he has a B line, but he has no pleural fluid here either. So he either just has plain old interstitial edema, and he's able to clear his pleural cavity because his CVP is low. Remember, you needed high CVP and high left atrial pressures to get pleural fluid. So now I'm expecting that IVC to be small, and when you look at it, it's normal. So, which all makes sense to me, that he's clearing his pleural cavity because his CVP is not that high. And the fact that his lungs are relatively patchy with their comments tells me I don't think he's gotten to the point where he has flooded his alveoli. That's why he looks so good. He's not sure of his alveoli, he doesn't have that lung assist, he doesn't have pleural effusion. His diaphragm is working just fine because there's no pleural fluids there. So it's not orthoptic. It's really the diaphragmatic dysfunction that causes the orthoptic, right? Just like in COPD, in people who have this, paralyzed from the neck down, they have diaphragmatic dysfunction, they end up being orthoptic. And then CHF, because of the pleural fluid, ends up being orthoptic. So this patient would fit in my mind as somebody who tried your best to get his comments to go away, and you still have a little bit of room to go, right? You can make that RV worse if you wanted to by getting this a little flatter. If you drop it a little bit, and maybe you'll drop that you'll get him dry. And if you get him dry enough. Okay, so if we really want to go into the weeds here, we can look at his neck pain if you want to. Some people look just here at the IVC, and so that's enough, because most patients, when they're ill, if they're intubated, they're lying down. It's hard to do manipulations on, but an outpatient do it all the time. And you can see again why a patient being able to telehealth me from home, if these comments are going away, is super important. I want those comments to go away. But you can use the same probe on a good machine like this and look at JPP using MSI. Yeah. And I've done this with some handhelds. There you go. And you can see here the carotid, and look how big that jugular is in the lying position. So this jugular, which is next to the, I'll put the carotid in the center screen and the jugular over here, and I'll compress the jugular. We'd have to sit them up to see what our level is. And I'm not sure.
He actually come with class 4 heart failure, class 4 withdrawals. He was much worse than what he is right now.
Yeah.
And as you said, he's been diabetes. Yeah. And I think he was quite orthotic.
Yeah.
4-5 days back, which again goes in line with what you're saying.
Yes.
And
So
I think he's better.
he's better, and that's exactly what it looks like. But his lungs still breathe fluid.
Yeah.
So you can't get him his lungs are no longer a sponge, his lungs are full, so he's only a few hundred cc's away to getting back to where he was. Look at it, so look when he sits up, guys. There's his jugular. I have my probe on his clavicle, and the arrow is at his carotid, and the jugular is right above it. It moves open every now and then. If you can have him hum, can you hum? There. See how big it gets? There he goes. There it is. So if you make him Valsalva, we can get him to get a little bit of fluid and show you what the carotid is. But it's not carotid, internal jugular is, but he is dry from the IJ point of view.
We've all been taught, as we prepare the next patient, we've all been taught that we have a lack between clinical congestion getting relieved and hemodynamic congestion getting relieved. I think it goes in line with what you're saying, because it still is hemodynamically congested in that sense, but clinically it seems a little dry. We have one more patient, Bruce, we have a little short of time. Can we have one patient now, and then we take the next patient the next time? In the hands-on, right? We can have the romantic heart disease patient.
You guys should ask questions, but it's.
Yeah, please, you all have to participate. Does anybody have any questions on these? We'll have lots of cases for the hands-on, but this is, you want to ask anything one-on-one, Bruce is ready.
So this is what we do on our team. Every admission from the night before, our team goes to that admission, even before they have an echo. And we do the fluid exam in a minute. And we call back Keshan. This patient's an heart failure, or this patient has gotten better from what you treated him with.
Right.
All right, we got a minute. Ready, guys?
So one question.
Yeah.
Since you do the clues in supine position, right?
Yeah.
Because there's so much difference when the patient sits and so the basic clues when you say you do that on the supine position rather than sitting on.
Correct. So, yes, so that's a good question. Because once they sit up, like if they're in a wheelchair, then I no longer trust the IBC. And I just go right to the internal jugular. When they're lying down, I do the IBC. That's a good question. That comes up all the time. You can do it with both. Okay, so we have 1 minute. Ready, guys? Oh, back to 16. And we're going to come up with the brain diagnosis in 1 minute. All right, ready? Here we go. I'm good here.
He specifically wanted to show you different types of, different etiologies of heart failure. That's the reason. So this is a classic growing valve of mitral stenosis, rheumatic heart disease. One thing is sure, Bruce, we're all going to go back with that blues mnemonic.
The clues, yeah.
Yes.
So we're on S right now. All right, let's do this. Okay, so this is what I'm thinking. We'll just go really fast. Here, your ejection fraction was, okay, fine, okay. Ejection fraction is normal. Look at it, kick the 7. There's clear mitral stenosis, you know. And the left atrium is huge. Okay, so in the AP diameter, there you go. But the good news is he has not decompensated. We have no interstitial edema. We have no pleural fluid. We have a good kidney on this side and a generous spleen if you like to get in the spleen. And then this side, the liver is brighter than the kidney cortex when I'm looking for the comments. And I always ask patients 2 things when I see this combination with a fatty liver. That is 1, how much alcohol do you drink? Or 2, what are your triglycerides? And do you have diabetes? Because that is, the association with fatty liver is so strong that I like to know beforehand if I have to screen for diabetes.
Is that what is MASH? The
Yes.
alcoholic steroid?
Yes, so, and that's what also I do is I give LTs, so I'm making sure it's not,
Why is it not congestion?
So congestion probably won't make it, until it gets cirrhotic.
That's a great point. That's a great point.
The brighter it gets, it's either fibrosis it's either fatty infiltration or fibrosis. But when you look over here, there's no pleural fluid. And then when you look down here, the main thing that struck me was look how high the left atrial pressures are compared to the right atrial pressures. So I knew at this point that his IVC better be small. Because if his IVC is big, then there's biatrial enlargement, which would either be AFib, which is very common in patients, which he is not that AFib because his right atrium is small, or he has pulmonary hypertension because the right atrium is really big. So we're going to look here, and he doesn't. So his right atrium is small, his IVC is small, which means he is quote compensated. And this patient here is somebody I would love to get on a treadmill because I want to know if he can let himself into pulmonary edema because you're going to ask the question, is he symptomatic from his mitral stenosis? And the way you know he's symptomatic, at least from this blue paradigm, is that he runs himself into pulmonary edema by developing comments making him stop his exercise treadmill. That makes sense? Because everyone stops because they're short of breath. But if you don't stop, nobody goes into pulmonary edema. I mean, you hope that no one's pulmonary edema, making them short of breath.
In a way, what you're actually invoking here is what we are all taught as second stenosis. I'm sure all of you know this. Second stenosis is when you have mitral stenosis, that's the first stenosis. But if you have a prevention of pulmonary edema because backward, you have endothelial secretion and then the PA starts contracting. So you have less blood coming in. So that's exactly what we say in ultrasound language. In that sense.
Yes,
because
small right.
Absolutely. So you have a prevention of pulmonary edema because you have less blood damming up in the lung to prevent it, actually. Yes, if we stress the patient, like we typically do, supposing you don't get a gradient, what we do is we make them sit-ups. That would probably invoke some form of pulmonary congestion. Great.
Just a final question.
So,
from a clinician's point of view, any correlation between density of these V lines and the diuretic responsiveness?
And the
diuretic responsiveness.
how fast does it correlate? Supposing you start someone on a diuretic, like a loop diuretic today, professor is wanting to ask that. How soon should you see a response in the
So this was looked at early on. This was looked at early on, and they used the dialysis population. And they took people right before they got dialysis and looked at them. They had V lines, and then they dialyzed them really dry, and they looked to see if there was So they came up with a figure of less than 30 minutes. So we see that most commonly on the CLUE team. When the resident who admitted the patient or the doctor who admitted the patient says, oh, this patient needs to come in, they have V lines everywhere, and they hit them with a wall of diuresis, and then we come in, and we go, what is that guy talking about? There's no V lines here, and they've already diuresed the V lines. And the thing that we rely on is that they still have a little bit of pleural fluid, because we know that's going to take hours to days to get rid of that. And so it's a good question. It can be gone by the time they get from the ER to their hospital beds. It could have gone with the diabetes.
Because what happens is many times the diuretic prescription becomes empirical. Some of the, like I remember if our own training about 3 decades back, because when you hit hard, I remember patients having even 500 milligrams of fluorescent, which I don't think any of you present generation could even. There was a tablet. Serenix and Lasix 500 mg tablet was available those days. I don't think anybody would have seen that also. It's no longer available. So from that, now it has come that we use actually small doses, maybe more frequent, and that is how the whole diuretic usage is seen. Number two, in the setting of a cardiac compromised patient, some amount of cardiorenal involvement with some renal compromise. Over-diuresis itself can be injurious to the kidneys. So I am just thinking from that point of view that could it help us to just strike a correct balance so that we don't under-diurese, don't over-diurese, and give the optimum and then get out of it.
Yeah, I agree that there's on that last patient whose IVC was small, I think that type of patient, you could get too dry. But on a patient who has a congestive nephropathy because their IVC is big and the venous renal vein pressure is high, and they're still only perfusing at a systolic pressure or blood pressure of 90 over 60, that person you diurese and their creatinine gets better. So I think you could use ultrasound to help determine who has congestive cardiorenal disease because of venous congestion versus preload poor perfusion from arterial perfusion issues. And the concept of a compartment syndrome of the kidney is an interesting one because it relates to CHF exacerbation. Because the compartment syndrome of the kidney, limited by corroded fascia, can only get blood to the tubules. The kidney is edematous because the renal vein is at such high pressure against the IVC that if you look at the renal vein, renal artery ultrasound, it becomes very spiky, just like you get with a compartment syndrome of the arm. And I think there's a research project there of following Doppler of the renal artery with diuresis, which kind of gets back to your question of what does the diuretic actually do in terms of helping the organ, whether it's the lung or the kidney.
I think one other point that all echocardiographers here talk about is that DR is not, when you have severe DR, TAPSE is not reliable for RV function. I think that's one more thing which should really assess well. Because when you have severe DR, like in this patient, this is a garden variety patient in Sathya Sai, or any of our teaching institutions. There's severe DR, so how do this RV function? We can't do it with severe DR. I mean, of course, 3D is around. But then this is also going to help us in that. If you look at it, it probably correlates well with that.
So this is where I love my relationship with Kesha, because we will debate. So if you look at my view, when left atrial pressures go up, isn't it great that you have a PFO? Because you can square a couple CCs across the PFO, and there's a trial now of creating an ASD to allow you to decompress your left atrium. It'll give you worse right heart problems, but those are okay. You're just not going to flood your lungs as easily because you've got a few more CCs that you get out of the left atrium. You created a larger left atrium for that patient, which will keep them out of heart failure. Okay, so that's one we debate about because he's closing PFOs, and I'm saying, well, I don't know. 20 years from now, maybe you don't want to close that PFO because they'll be heart failure. And the other one is TR, because if you believe that 1 cc of the RV outperforming the LV will lead to 4.0 liters over time in an hour, what if you hurt your RV? And how would you hurt your RV and make it 71 cc's go to 70? Well, we said diurese it because it's preload dependent. But what if you induce PR? Then again, you'd be shifting the problem to the peripheral venous. You'd have more people that be, oh my gosh, but your lungs wouldn't feel the burden. And the only issue there is, if you hurt the RV enough, you'll lose your blood pressure.
Okay.
Then you're stuck. So, but that's why, RVMIs, it's hard to get them into pulmonary edema because you just got produced in that for the lung. Yeah, exactly. It's just hypotension.
In fact, they go more into desaturation because of VF opens up attention.
Yes, that's exactly right. That's exactly right.
I think we had a great session.
Yeah.
Bruce. We'll actually come to this discussion as we have the hands-on session. We'll now break for tea. I know we are late, but we can regroup ASAP, then we'll have the academic session. Thank you so much. We have the third patient in the hands-on session. Thank you, Bruce. I request all the faculty and delegates to please join us. Anybody who is not registered yet and has joined us, please register outside. It's anyway free, but we need to know exactly what is the head count. Thank you.
So again, whether it's primary or secondary, and using the typical sort of Pontier classification, if there's normal leaflet motion, excess leaflet motion, or restricted leaflet motion, gives you different characterizations. And then we use different interventions depending on what the etiology is and what the mechanism is of the So I'm going to give an example here. So this is a typical 70-year-old gentleman who presents with heart failure and is already on guideline-directed medical therapy. And I will pause and just for a moment and say that although we're not going to discuss guideline-directed medical therapy, that is obviously first-line therapy, and patients should be optimized on this before considering interventions. Okay, now on to the imaging part, which is the most fun for me anyways. So we have this patient here, you can see this is a color compared view. These are all TV. The images that we show predominantly, so we're looking through the esophagus, looking forward through the left atrium, over here's the left ventricle, valve. So you can see there's significant MR here. This is transgastric view, again, with color compared, so with and without color. And you can see the central nature here of the color. We then do the usual kinds of things that we would do to look at the MR severity. So this is using an EROA, the typical we measure the Keyser radius, do calculation involving the alias velocity, and a trace of the MR jet in order to get the MR EROA, as well as measure regurgitation volume. And then this is the vena contracta area, which is done on 3D, which is another adjunctive method of looking at the severity of the mitral regurgitation, in addition to the pulmonary veins and looking for any systolic flow reversal. So this patient clearly has severe MR and is in heart failure despite optimal medical therapy and needs to have an intervention. So we'll do several measurements as well pre-procedurally to make sure that having a transcatheter intervention is possible. And so depending on whichever transcatheter intervention you're talking about, there's different criteria. For mitral valve interventions, particularly for mitral clip, we want to look at the mitral valve area and we want to look at the mean gradient to make sure that the risk of stenosis is low. So we require a valve area of greater than 4 centimeters squared and usually a mean gradient that's less than 4 to 5, although the mean gradient in the context of severe mitral regurgitation may be overestimated and overestimating the risk of mitral stenosis. And we in our center will still continue to do the procedure if the gradient is slightly elevated. We also do several other measurements, things like measuring the length of the leaflets in order to help us decide on which size and type of clip that we're going to use. So there's different clips that have different arm lengths, and so deciding on which one will be feasible depends on several of these measurements. And then I just want to take a moment to say that we do have a very important role for using 3D both in planning and inter-procedurally during these procedures. So this is on the left, a 3D with color, and on the right, same 3D without color. And it really does help us to clarify the etiology and the location of where the jet is coming from in order to plan our procedure. And I'll show you the inter-procedural pictures as we go where we're using that. Okay, so in this patient, we decided to proceed with the mitral clip. So this is a bicapable view here with an X coming through it. And you can see here that this is the catheter, which is coming out through the IVC, and we see it placed here in an SVC. We then sort of move that catheter down so that it's actually in the mid area of the septum, and then look at the short axis here. You can see that this is sort of out of the posterior, and then we would typically measure the height in what is more a typical four-chamber tube. We like to have an adequate height of at least around 4 centimeters so that we know that we're in a good position. Then we'll proceed with So then we'll proceed with the transeptal puncture here, and this is the dilator coming across, after which we put in the sheath, and then here you can see the mitral clip coming out of the guide. And again, we'll use 3D images. This is a multiplanar format. Depending on which company you're using, the different specific pictures are slightly different, but it's all the same concept. We use a multiplanar view here, and then we get a nice 3D, so we're able to see the orientation of what we're doing very much detail. So then we position the clip over the valve. Here we have the clip slightly open, and we'll look at it on 3D to see the alignment. So we want to make sure it's like this nicely located. Again, this is the aortic valve here, left atrial appendage. We want the clip to be nicely located in this AP location, and also in the location of where the color was, which we recall is quite central. We will then cross into the left ventricle here, and we have an X-plane view. We often use these X-plane views to really help us. So this is the typical bi-commissural view. So this is lateral, this is medial. And we're trying to go in centrally here. And then when we X-plane through that, this gives us the view where we just see what we have here, where we have anterior and posterior here, which is considered our grasping view. So this is that grasping view, and you can see we have the clip in the ventricle here, open, and we pull it up close to the mitral valve leaflets. We make sure that the leaflets are nicely falling in over the leaflet, over the arms of the clip. And then we have these graspers, which are these lines here. The second line that comes down. And these graspers have actually little sharp bits that hold the leaflet between the arm and the grasper. And we can see that that's bouncing normally, nicely, though we'd like to see it. And then we close the clip. And we're able to see that we've had a reduction in the MR here. There is still a small jet MR, just medial to our clip. And we can see that there's a nice ridge here. So we go on to do basically the same thing with the second clip. So you can see here the second clip that we're placing here on the medial side of the first clip. And after we complete that, we have just a little bit of residual MR. And you can see the pulmonary veins that were previously reversed are now upright, and the mean gradient is 3. We usually go second gradient up to 5. So this is a case of where we are able to get a reasonable result with just mitral clip. And then this is the final 3D. So this again is the short axis of the mitral valve. If you recall, P1, A2, A3, P1, P2, P3. You can see the first clip here, the second clip here, and just a slight amount of residual MR, which is considered mild and acceptable. And then at the end of the case, we will typically look for the ASD, which is iatrogenic. You can see the wire that's going through here. And we usually look at the color as well as ACW to ensure that predominantly or completely left to right flow. And typically, we will not close the ASD in this situation. And when we do the repeat ultrasound, so around 3 months, the ASD will have closed on its own. But as you heard from the last talk that Dr. Kimura gave, that we know that it's important in some of these patients that the ASD actually does allow some of that improvement in terms of allowing some escape of any of some of those extra cc's of blood that he was talking about in terms of the difference between the RV and the LV performance. So this is also, this atrial septostomy is what he was talking about, is something that they're doing as a therapy in and of itself. Typically, we may not close this unless there's some right flows. So not everybody can get clipped. So there are patients who, like this example here, where there's quite a horizontal coaptation line, and typically when that's the case, it's very difficult to get it to fall onto the clip in a traditional fashion. And these are patients that tend to be related to mitral regurgitation because of annular dilatation or atrial dilatation. And then these patients, because of that, would normally, if they were going to get a surgical approach, would get an annuloplasty ring. And so these types of patients don't typically perform well when we do just a mitral clip because of the horizontal coaptation line. We're not able to get to bring those tips together enough with the mitral clip in and of itself. So using this traditional mitral clip method would not have worked for this patient. So actually in this patient we did an interesting hybrid approach where we did a percutaneous annuloplasty ring followed by a mitral clip, which was a hybrid approach. So this was actually the first in man percutaneous annuloplasty ring with this specific device. We did a transeptal puncture. You see the device here in the left atrium again. This is the surgeon's view, so we're looking for the left atrium down onto the mitral valve. So we see our device here, and it's coming here out as we bring it out. First, it just looks like a straight line, but then it sort of opens up here, and you can start to see the two tines. This is out further on the sheet, and again, you're seeing the two tines here, and then sort of more completely out, where it's a complete circle, and again, you're seeing the two tines. And then those tines actually allow us to turn the clip into the orientation that we want. So it's more like this. And then there's actually little spokes that come out at the medial and lateral commissure in order to tack the annuloplasty ring down to the mitral valve. So this is actually what it looks like at the end. And there's still MR you can see centrally, but this is with the annuloplasty ring in place. And then this allowed us to actually then go on into a clip inside of the ring. So we then placed a mitral clip here centrally within the ring. And you can see there's just very little residual MR left compared to the severe MR effect. And this is just a transthoracic image here, just allowing you to see this. You can see the annuloplasty ring here, and then also the mitral clip. This patient actually ended up getting an ASD closure because they had the hole that's needed to make the septum is quite large. And actually, we didn't close it acutely, but had to come back and close it later because the patient did have significant residual ASD. Okay, and then finally, I'm going to talk about some of the transcatheter valve replacement options. And so these are the typical valves that you would see for, some of them are specific for transcatheter valves and some which are used in the mitral position, but some are also valves which are used traditionally for other things, like the CPA3 valve, for example, that's used in TAVRs. They can be used as a valve in valve or valve in back way of replacing the valve transcatheter as opposed to using it as traditional flashing for the aortic valve. And then this is a 10 dime, which has a little apical catheter. So typically, these are patients who would not qualify for or are not usually amenable to the usual clip due to either calcification of the valve, or they have mixed MR and NS, or they have predominantly NS, but are patients who would not be otherwise surgical candidates. And so the difference is between the 10 dime and some of these is that the 10 dime typically can't be used if the patient has already had intervention previously, whereas some of these transcatheter options can be used in a patient with a prior valve. So here's an example of patients that we did a 10 dime valve on. So you can see here, you see a lot of these used today with Dr. Kimura. You can see that we do have reduction in the LV function, and the left atrium is quite large here. We can see the LV diastolic dimension is 61, and the systolic dimension, which she was also mentioning that people don't look at maybe often enough, was quite large as well, 53. This patient was already on optimal medical therapy, yet had significant residual MR remaining, which you can all appreciate here from these groups. And you can see that there's not only a functional component, but also a degenerative component to this patient's MR, so they had mixed pathology in terms of their etiology. So play a little bit with show, so appreciate this. So this is where we use a lot more of our 3D information that's outlined in those papers that I talked about at the beginning, in order to try to use some of our 3D techniques to help us plan and guide some of these procedures. So this is a multi-planar approach. So you can see here, this is your typical aortic valve here, and this is the entire valve B, an anterior leaflet, posterior leaflet, and then an X came through that, which gives us more of a typical four-chamber type view, and then short axis view, right where the spine is over here, and the equivalent 3D image. So typically we'll use this for planning because this is the transapical approach. And you can see here this little dent that's coming in here periodically, and in fact, this is because that is actually the surgeon's finger as to where they're planning on doing the apical puncture to make sure that they're through apex. So they will press externally and will watch with the TEE to make sure that we are well aligned and that that's a good spot for the puncture. Then a wire will go up from the apical puncture up through the valve into the left atrium. So the wire here. And here's the wire without the full just to explain. And then they will glue sort of back and forth across that valve and make sure that they're not getting caught in any of the cordi. And so we'll visualize that, just make sure there's a clear path for when we're putting in the valve. And then this is the guide that's across. And this is now the surgeon's view again, where we're looking at the valve that's now coming out of that sheath into the left atrium. And here it is opened up. So we haven't, and you can see here that it's not fully open. The tendon valve actually has a shorter posterior skirt, a longer anterior skirt, so it has a directional orientation. So we'll rotate it with the left atrium and then bring it down towards the level of the valve. And then you can see it kind of opened up here, and we're sort of rotating. And that's the color. We now have the valve opening deployed here. You can see actually the valve leaflets are opening well. This is the, you can see that the skirt for the arms are well posed. So this is here the aortomitral continuity, and then here on the posterior wall of the left atrium, you can see that the leaflets are opening well with no residual regurgitation and no sort of paravalvular regurgitation here. The biggest risk with these types of procedures is the risk of having neo-LVOT obstruction, which is that when we place these valves, because there's a component that's here in the LVOT, plus we're not actually getting rid of the inherent mitral anterior leaflet. With that, we get pushed here, and then we can have LVOT obstruction. So we do specific measurements on the CT scans in order to try to make sure that we can predict what the neo-LVOT will be, and then are able to make sure that there's no obstruction here on color prior to fully deploying the valve. You can see the valve here again opening nicely. And this is the gradient at the end. And this is the apical approach that we have. So you can see the little tip there, which is this apical pad here. Any questions about that before I go on? Okay, and then I think I'll just take the last minute to talk about valve and valves, or valve and back, which can be used for bioprosthetic valve dissection, or if the patient has severe mitral angular calcification. So this patient actually has a bioprosthetic valve, which you can see based on these 3 dots here. Well, this is the name.
As you get it on stance, just wanted to ask you, what is the anticoagulation that you give for this?
Yeah, so typically, this patient had the tendine valve.
Yes. And how long does it continue?
Yeah, so that patient had AFib, so they're on lifelong anticoagulation anyways. To be honest, the vast majority of these patients are on anticoagulation because they have atrial fibrillation in the context of this mitral valve disease. So we don't typically get to avoid that. But otherwise, they would be treated like a bioprosthetic valve. So typically that would be up to 3 months, and they would go off their anticoagulation if they didn't have another medication. Okay, so I'll just show this briefly here. We're almost done, and we can show right after this. So this is, these are typically done in a cath lab, but usually just with thorough guidance rather than necessarily TV guidance. So this is the patient who had bioprosthetic valve. You can see the 3 stents in place here. And again, this is based kind of like the way that TAVR valves are placed, with just thorough guidance and transthoracic sort of assessment afterwards. So balloon comes across here, the valves and deployed, and the valve in place here. And okay, so in summary, we talked about, I used mitral valve intervention as an example, but this same talk can be did with any of the different types of interventions: tricuspid valve, mitral valve, aortic valve. And again, it's sort of paralleling the decision making that we make when we're trying to decide on a surgical intervention, whether it's best to done with an annuloplasty or replacement or repair. So similarly, we would decide what type of interventions are based on the patient's anatomy, and again, deciding between surgical and non-surgical options is more of an overall picture perspective, but in the context of on the any other questions? I mean, so
Is it average trial? Is it naturally not for rheumatic MR? But subsequently it is changed now?
Yes, typically the risk with the rheumatic patients is that they tend to more commonly present with some degree of stenosis already. And when we're doing the mitral clip, we're sort of trading off some degree of stenosis, hopefully mild or less, for the MR that they have. So because those patients tend to already have a propensity towards that, we typically wouldn't use mitral clip as a preferred option for those patients. But we do have patients who tend to be in the midst spectrum of MR/MS who can get other transcatheter valves. So for example, we're going to be doing a case of the day after I get back, and so to a 10-9 procedure on one of those patients. And so that's potentially, we now have other better options for those patients. So typically we will use something else that we know is going to have a more prolonged and beneficial result for the overall patient.
Yeah, apparently the guidelines is recommended I should take for both primary and secondary MR. So your experience is more primary or secondary?
So I'll say that because like in Canada, so we've been doing about 50% in primary and 50% secondary MR for 10 years. But I think that, for example, we asked some of our American colleagues that maybe that hasn't been quite ratios that they were doing, but especially based on the collapse trial, we know that there's significant benefit. We know that there's significant benefit in the secondary MR population as well, in terms of compared to that. So more and more our surgeons, particularly in the secondary MR patients, are using it very commonly for these types of patients, where and we've always been using it for degenerative patients as well. So I don't know if you would say different experience in the States, but in Canada, our experience in our center, which is one of the oldest centers, is about 50-50.
In the US, it's DMR is primarily in surgical correction. So in my practice, all the primary MR is treated by the surgeon. I get to evaluate them with the surgeon. We have a really experienced robotic microsurgeon, so he does all the robotic micro care on primary MR. And then any secondary MR, I fix it with the micro. That's what.
Yes, I think like the secondary MR, the primary choice that you do it as a transcatheter approach. And then for the primary MR patients, although we do 50-50 in terms of our numbers, it's because those patients are patients who would be otherwise surgical candidates or high surgical.
We wanted to ask a couple of questions, Tas. Since you trained in a center with very high volume of structure and you are into mitral clip. For our students, can you just tell us, you look at a valve and then you say, this is not a case for mitral clip.
would those characteristics be?
So there's traditional criteria, which is, we call them like green cases, people who were always able to do, and a lot of that criteria are based on some of the older trials, like Irish trials. So for example, a mitral valve area of 3D, usually greater than 4, or having no significant gradient, or having no significant gradient progress. In addition to being able to have good imaging, obviously, so that we can follow the procedure, making sure that we're getting good insertion of the leaflets and things like that. So there's anatomic components where there would be higher stenosis. There's components which are procedural issues. So for example, if you don't have good images, or the leaflets are too short, or they don't have enough either coaptation overlap, the gap is too big, the tissue is too thick, where there's calcium either on the tissue itself that would normally insert into the clip, or the subvalvular component that's going to get in the way. So there's like some technical features in terms of that. So there might be some technical issues, and then obviously there's the overall patient risk. So for example, if you have a primary MR patient that they're not that high of surgical risk, they should go for surgery, where you're able to get excellent repair, especially at a center that has good experience. So I think, there's a sort of variety of determining factors, but I think, the more and more experience that we've had in our center, like there are certain things where people say, well, have we never, which we now will do people, for example, if their mitral valve area is 3.8, we might still do them. If their gradient is above 5, but we have severe MR, but we think that their valve area is good, we'd say, well, maybe some of that MR is, or a lot of that MR is related, the gradient is related to the severe MR, and as we improve the MR, the gradient does actually come down. And then also we are looking at the bigger picture. So in some of these borderline patients, do they have another option? So now there's things, for example, like Tendyne available. If we have an alternative option, should we just go straight to that option? Because if we try to do a mitral clip, for example, and we get a suboptimal result, then those other options are off the table. Well, surgical options are still on the table, but something like a Tendyne wouldn't be an option for them. So we would have to decide before we put in any clips if we think that maybe there's a better option for them instead.
And one last question which was being asked is, how do you manage radiation? Because you're standing next to the C-arm. So how do you avoid radiation in these patients, or how do you protect yourself?
As the echo person, you mean, or as the interventionalist?
No, because the interventionist is standing just next up. Of course,
yeah.
Everybody's at risk, but then you have your key hanging there and you're standing there all the time. And that's also for the anesthesia work.
Yeah.
They can of course go away a little, but you are doing it real time.
Yeah.
So how do you manage radiation?
So at our center we have this, I can bring the contraption, but a picture of the contraption, but we have this a big lead.
You stand behind the contraption.
Yeah, so there's a big lead shield. It's clear, so we can see what we're doing. There's a small blue limit where we put our arm through
it,
and we have the TB probe in. It's actually quite awkward. So there's times where we're standing, like the machine is here, the patient is here, we're standing like this for, like 3 hours while we're trying to, put in clip 1, clip 2, we're trying to do all these different things. So it's a bit of an acrobatic act sometimes in terms of the logistics of that. And some sites, based on where their CR is, have to have a position on the other side. From a TB perspective, for people who do TBs, their TB facing this way, but with my arm this way. Normally we TB on the other side, so it's kind of a mind shift. It's kind of like scanning to the right and scanning to the left. You just have to kind of get used to that, those sort of logistic things.
Acrobatic was a good word.
One question that you said when you have those big valves, I'm just correlating for us in the OD, I'm an anesthesiologist. Is there one thing that you would say that this valve would not cause an LVOT obstruction? Some dimension that you would say, like, after deploying it, you're not going to remove. It's expensive, like seeing no one in the OT. So there's one criteria that you would say that this valve can cause an LVOT obstruction.
Talking of a surgical valve.
Yeah, a surgical valve, a bioprosthetic, anything which is big. When we see that sometimes we get an LVOT obstruction and bioprosthetic valve, something which can predict that.
Yeah, so actually, before we do any of the transcatheter valve, either lock valve or a Tendyne type procedure, everybody has a cardiac CT done, and we actually use the 3D software to try to predict the neo-LVOT. So we actually, I don't know about my computer, but
We do specific measurements where we will look at it in 3D and actually put in a model of the valve and then use that to then You calculate. create a reconstruction of the valve in this patient. Yeah, exactly. We superimpose the valve, the exact valve we're going to use over the patient's CT images and then actually calculate the valve weight. So typically that's done, the company will sometimes help with that, for each individual type of valve to help do some of that reconstruction. It doesn't necessarily have to be done on site, but the CT images are done on site.
Because even, I guess even the other companies, they actually calculate the new aortic area. I'm sure they also, so they call it the new aortic area when they put in a tower. They sort of model it, see it, and then see the new aortic area should be a certain. So then it prevents.
One more one, you have problems anytime when your valve size has been an issue and you have the LCs getting impinged or you have a block or something coming or it's anything that you would specifically see or the the left coronary left subclavian artery.
We have not seen that. With the tendon, we have not seen that. So it actually typically doesn't, it sits on the inside of the left atrium and there's no impingement, there's nothing poking through, so there's nothing to impinge. So typically that has not been this time. And then for the valve-to-valve one, it's because they're inside the framework of either MAP or inside an already existing valve, typically that isn't as much damage.
Thank you, guys. Thank you for that wonderful lecture. Please give us so there is a lot to learn in this afternoon session. I love this. I know we're in short time. I'll try to make this as concise as I could. The whole idea of having this talk was just to bring out the importance of echocardiography in as a vital tool in cardiogenic shock. This is actually, I'm going to be skipping the theory part of it. I show some really interesting cases which actually put the point in perspective. So as I discussed, I'll be going on these headings, which is basically what shock is all about, how do you focus liquid, and like what is the decision making algorithm today in shock. So who are these? Anybody? Any written answer there? Dr. Swan and Dr. Gans. And what I feel this gentleman has done here, this man up there on the top left, is that he has sent them to church. So there's no more Swan Gans. There's only echo. The way he described today morning, there is no Swan Gans anymore. So anyway, so this is, we all know that CS kills, cardiogenic shock kills. It's primarily because of shear impact of the myocardial performance, which results in congestive cardiac output and hypoperfusion. And as we all know, in an acute situation, acute MI is the one that leads to almost 80% of the patients being in cardiogenic shock. There were a lot of guidelines, a lot of proposed guidelines, shock, IPT, SOC 2, EHS, ESCHF, ESCHF, etc. And coming in the other guidelines. But then, coming out of the guidelines, one should realize that essentially it's a simple clinical diagnosis. You have right heart failure, you can have shared findings, and you can have left heart failure. Usually, right heart failure is second to left heart failure. This is an entire table of causes of cardiogenic shock. Though in common parlance, what we see is either mechanical complications of the MI causing it, acute aortic syndrome causing it, recession causing it, acute valvular hemorrhage causing it, or generally a massive pulmonary causing it. I would say this accounts for 75 to 80% of what you generally see. Of course, you can have lateral support and etc., all of that. But then the issue is why do an echo in cardiogenic shock? This is aptly been exemplified by Bruce and everybody else who is speaking in the academic sessions. Essentially, it's to identify a source. You need to know what's it coming from. Number one, how is the volume status, how is the fluid responsiveness, and how do you guide treatment. That's it. These are the four cardinal questions that you have to answer as you're going these. So we also know that in different types of shock, we can have different clinical findings. Particularly, it's important to know that resistant vascular resistance increases in all kinds of shocks, except deep shock, where there is, the patient collapse.
So they respond to means much more than the others do. And of course, hypovolemic shock, one must remember that the CVP is low. So you need to give fluids. So this is old school traditional way we have done it all along. We can talk about focus as of course as a new modality, but this is very old school when you all treat. So this is generally isn't a tamponade because we need to rule out things that kill and kill immediately. So is it a tamponade? Is it an MI? Is there LV and RS systolic dysfunction? Is there valve pathology? Because these are things that push a patient into pulmonary edema in no point in time, and then you really have to intubate them and the patient goes sick very fast. Echo and cardiac shock needs to be performed early. It's important to actually do it early because it establishes the cause of the shock. It gives you about the LV and RS, the regional systolic function, global systolic function. Regional I mean because it's important because it's key and regional. Generally it's regional. So you know there's an RWMA. Since we have a lot of text in the audience, RWMA is generally regional wall portion which is more ischemic in origin than a global LV function. And you can of course rapidly diagnose mechanisms of shock. You can see the LVF dynamically at a point in time. Of course, it's important to see dynamically to see temporally how it progresses or sort of worsens. LVF is not always replaced in shock. Remember this because it is the same case of septic shock. You may get a normal LVD here, but still the patient will be in shock. T is not always easy, but then T scores over TT because if TT is not able to actually produce good images, and it happens in a lot of times, a lot of patients with emphysema, lungs, smokers, pneumothorax, etc. Or if you have chest wall deformity, T comes into play. And it's the first choice modality in some conditions where you should know that if there's an acute prosthetic valve dysfunction or the patient got an acute valvular recursion, if the patient has a massive PE or anyway intubated. So all of these you could actually, you will not be able to take a patient to the CD very easily because though it's always nice to see clots on CD, it's not always possible because they're intubated and sick. So it's a great modality in those patients. Why do we need focused echo? We need focus, of course. Focus to prevent this focus, you could call it focus, what is going on here. So is it always practical to do a complete echo? Because this is what you always have to do. You have a 2D, you have an M mode, you have color doppler, you have TDI, you have X, Y, Z. Is it always practical to do it? No, it's not. Because the more ill the patient, the more is the critically ill the patient, I would say the more is the challenge to do echo, a complete echo. There is no time to do it, and it's difficult. It's rapidly changing physiology. You could have positive pressure ventilation. You have this lungs coming in front of your heart. You're not able to see anything. Tachyarrhythmias, AF comes in, BF comes in. It's not easy to do those echoes here. So what is a focused echo? A focused echo essentially is a surgical strike. You have binary questions: is it there or not there? That's it. So it's important to identify LVR abnormalities. Do a basic study, just as exactly what Dr. Bruce showed you. Do this, and you get an answer. There is no point of going for a verbose detailed echo. There is no other bedside tool which can offer a similar diagnostic capability, which is why I said this is the invention of the 20th century, which are the first kind of here. So what kind of focus do you offer? First line, to say shock patients, diagnosis of is it cardiac or non-cardiac pulmonary edema? What is the fluid status? How is it? How do you have to replace? How fast? How is it tolerated? Individual management of critical patients are further monitored too. It's even become a consensus statement now in society. And formal echo was the focus echo. So essentially answer 6 questions. And I think this is for all the students to understand this. If you're writing an answer in the exam and you're seeing a patient in real life, this is what number 1, is it a tamponade? Is it a significant pericardial lesion causing a tamponade? Number 2, how is the LV? Number 3, how is the RV? Number 4, how filled is it? How good is the IC? 5, how is the ultrasound artifact in the lung? You can see about focus, which will be focusing on in the entire hands-on session. And number 6 is the acute MRTA. That's it. If you answer these 6 questions, generally you can get by with 95 to 99% of your patients. And answer these 6 cardinal questions to start with. I'll show you a few scenarios where we really use this. This is the fast echo, what we call it the fast echo. Anesthesists are very fond of calling it fast and feel and freight and all kinds of acronyms that they use. So I'll show you a few cases. This was a case. We always love showing this. I love showing Dr. Bruce. This is his first visit here. It's something that he touched upon in the last case. He said you could have a patient with acute LA enlargement, and how you could say let's create a PFO. Well, this was actually done in this case. This is a patient who underwent the stenting. Day 3 of the stenting had acute pulmonary edema and was brought in the night here. He was staying on campus, so he was brought in the night here, and all of us had one thought in our mind. is this acute stent thrombosis. He was so bad, he was intubated in the ER, taken up to the cath lab, thinking it is ST flowing stent. TV3 flow, nothing in the stent. But when I time he was intubated, and what he actually had was an acute MR because something was an rupture. And this was day 3 post PCI. We were fooled by his stent, saved by an echo. We actually ended up doing a BFO. Dr. Raj, who was the teacher, was here, ended up doing a BFO on this patient. Decompressing his LA, his pulmonary edema vanished. I had an anesthetic standing here, Dr. Sunil, who had intubated him. His tube cleared in front of us, literally. And then we guided over the night. It was around 2 in the morning. Who was like, Treatment was here, I was here. Raj was here, we were there till 3 in the morning, 6 o'clock, we were taken up for an NPR. And this man, made it to really well. So this is where it helps. This is the severe MR which is actually swirling MR in the LA. The transeptal puncture was that, so you can see that that's a transeptal there, which can squirt blood from the LA to RA. This is exactly what we're talking in the last case. So eventually I'm going to repair the next. This happens, of course, at a cost of forward output, but then it saved his life. Second patient, day 10, angioval MI, no license given. This is a typical patient you would get in a government hospital, in a teaching hospital in India. No revascularization, no lysis, classic short of breath, cross diaphragmatic failure. You can see that there's a big hole there, a huge hole there. So VSR, and he ended up with a post in a VSR device in a hospital, post device echo, creatinine with a cost of 4.8 when it started, and 3 days or 4 days it was 0.8, and this man managed to go. These are the things you can really diagnose. On the fly, if you think of a mechanical complication, this is where, that's what I said, you have 90-95% of cases which come like this, which have, echo was a game changer here. This is just a small cartoon I've made. So what was happening was, after he put his device as well, we wanted to make sure that it's not catching on the tricuspid valve. Anybody, all of us who do intervention are always scared about this. Suppose it catches the valve on the side, some kind of a cording on the side, and it can actually not allow closure. So all this can be seen very, very well with the key. It was shown very well that there was no information on anything, and this man made it really well. Another patient almost entirely close by echo. This all our interventions, all of us will agree, this is something that happens, they have down techniques, so you can't give them. So this is the first shoot and the last shoot, that's it. Everything else was done by echo. Everything else was done by echo. 15 mm of contrast, the whole thing was done. You can see the VSR down there. There you can see the actual spot of contrast from delivery to RV, and this man came cross heart failure and underwent a device position. This entire thing was on echo. Displayed, it's a long look, but anyway. So it was done on echo, and you have almost a minimal or no resolution there. The device position is confirmed by echo down there. See, it looks very nice. So all these are cases. This other patient who was a case of non-Hodgkin's lymphoma on treatment, and he had bilateral fidelity on short of breath, class 3 short of breath, and class 3 MIHE short of breath, and then constricted feeling in the chest. You can see that there is a massive pericardial effusion there. You have early national collapse, and you have a significant immediately there because these are all images from the ER because there's not even time to take it to the echo lab, do a full echo. It's not possible. Keep up from there, CP, drain, that's it. And the RNA was even delivered. It was an interesting case of what we call as effusive constrictive pericarditis. Eventually turned out to have effusive constrictive pericarditis, and then was treated body. He had acute tuberculosis as well, 6 to 7 months now, for which he was treated. There's another patient, 58-year-old male, smoker, no case of hypertension, acute onset chest pain. This is again a cardiovascular patient that all you see in your ERs. So we see this show, inferior in mind, he was thrombolized, but he deteriorated within 15 minutes and had to be intubated. Why? Because this is what happened. So this is something that, this is all taken from the ER. So these are all, images. One of the students would tell me, why did it happen? You have to check. In every inferior mind, you have to check both upper and lower impulses. Because the flap dissects backwards. It actually involves the RCO osteo. And if the patient has got inferior mind secondary to a aortic dissection flap and you end up thrombolizing him, you're going to cause a mess. And that's what actually happened to this patient because it was launched in another hospital, he was lysed and then transferred. They said, are you going to undergo a primary PCM? He said, no. They lysed him. By the time he was here, he was pulseless. And this is 15 minutes away. We just have this hospital across the road. He was really sick. This is a huge dissection flap. And this mortality is by the hour. So these are things which you can really pick up, on a focused echo. This is where I think focused echo comes in really, really well. This is another patient, another dissection flap. You can see that up here. You can see the dissection flap very clearly in the aorta here. This is a smoker, shorter breath 15 days, you did a COPD. COPD is, chronic obstructive pulmonary disease, no acute chest pain. No real acute chest pain, but then was found out to have a huge flap. Patient 50-year-old male, this happened a couple of I think years back. So, 50-year-old male, this is COVID illness, shorter breath, last 4 to 5 hours, McDonald's sign positive, clearly massive already was. So I think, by and large, when you have a focused echo, again, I wouldn't mind doing this to the small cats, but then when you have a focused echo, this is exactly what, you have this kind of a mental picture. What are you going to do about it? So you see the E by E, you see how it is. Is it type 3 LVDT, type 1 LVDT, and then it goes along. The LA pressure. A lot of this verbosity has been taken off by the purpose. Echocardiographic shock, just for the sake of completion of my talk, I'm going to be talking about the next few slides, but then I'll go fast. You all know this, echocardiographic shock, you have the LV and diastolic damage is what you take, and of course the kissing wall sign, you know this, you have the kissing wall sign where you have a compressed heart and then a going of the integrated receptor. You check with fluid responsiveness, you give at least 50% of cardiac output increase, you have to give a rapid bolus of 550 ml and see 15% change in the cardiac output. You can do this with VTI. There is no way you won't put a catheter in such cases because they are quite safe. You just take VTI, that is time velocity integral, and you see the improvement in the integral side. You have a lot of interactions in this. You see the vena collapsibility. I talked about in the next 2 slides, and passive net raising. This is the normal LV diastolic area assessment, which is usually about 15 to 22. If it is low, it means there is severe hypovolemia. IVC signs collapsibility. Our is now talking about this because this is something that they also face. You can't keep on putting, PA gas in this patient. So then, how do you decide the fluid volume? IVC signs collapsibility. You have different measures in spontaneously ventilated patients and in mechanically ventilated patients, of course. But then generally, this is what we've all been taught: how much of the diameter collapses. What is the diameter number 1 and how much is collapses? So it tells you what you started and how much you can accept. Of course, mechanically ventilation is not as great because they say that central lines will be much more reliable, but then average accessibility can still be seen in these patients. Another thing is about SVC. SVC collapsibility. That's another thing which is quite important. You can see the SVC collapsibility also when you do a DEE. So you see in terms of what is the index of more than 30% or 35% they say to decide for responses. Stroke variability can also be seen. Passive noticing is a very simple thing where you just have to passively raise the neck of the person, and you see in terms of increase in cardiac output more than 12% in case of fluid response, because there is a simple transfer of blood from the lower limb to the abdominals. A quick look echo in cardiogenic shock. What should you see? Number 1, is it sedated? Because that's it. I told you about 80% of cardiogenic shock. Is it a mixed type? Rarely it happens. Sometimes you have a mixed shock. Sometimes hypolimic, and of course also having a CAD associated. Or also sometimes it happens about the etiology. You have an unexplained saturation falling. Why? Because you have atrial polyemi, the RAS, RA pressure that listen, you have a right to left shunt, and then it saturates badly because there is a shunt there. It's nothing to do with pulmonary. You auscultate that can clean. So that's why the sat slow. That's because you've got an RPMI. Electrical function can also be seen, and pre-existing mark can be seen. A lot of these have already been discussed in literature and these. Equal obstructive shock. Obstructive shock, acute PE, cardiac tamponade, and of course dynamic ventricular obstruction. Acute PE, that is pulmonary embolism, you see your classic McDonald sign, you see the type of amount of TR you can see because they are low RV pressures. That's one thing you should know. When you talk of acute embolism, the RV pressure doesn't build up. So you have low pressure because the RV is not contracting well. You can use TAPSE increase and increase of S-prime velocity, the RV dysfunction. RV S-prime velocity for the RV dysfunction. This is obviously your, so a McDonald sign, the RV gets completely ballooned out. McDonald sign again. Cardiac tamponade, another thing that you must look for. RA wall collapse, RA additional collapse is much more sensitive and happens earlier and specific than, of course, other signs and in case of emergency drainage. Diameter obstruction, you see this commonly even post-operatively. It's not just of HOC. It happens when the LV, you give in an empty heart, you start giving anatropes. So they see a lot of it in the post-operative suite in which you give fluids so that you can actually build up the volume and then the atrial obstruction comes down. The classic Dapper sign, which you all know. 70% hypovolemic shock. I sort of touched upon it earlier. SVR is low in one, SVR is high in the other, and IVC would be dilated in a normal in septic, but of course collapse in a hypovolemic shock. Septic shock, vasoplasia, essentially it's almost always reversible in the early part, except when it is too late, and other lesions, infective endocarditis should be looked for in patient septic shock. There has been a lot of talk about spectral tracking as well, where they used, along with Akshay scores, they've used spectral tracking, combined use of both, and they found out that there is a much more facility in actually diagnosing septic shock when you actually combine GLS with Akshay scores. More of such studies, of course. So cardiomyopathy, we have to talk about it because this is something which is quite often missed. It's generally known to happen post stressful event, etc. And hyperthermic, and it's completely reversible. You have to do you may end up doing an angiogram, it's completely normal, and as you go temporarily in that, it tends to improve. So all of these are the characteristics of that shock. Of course, if you're talking about focus, is something which is today. This talk till now is what I trained. This is what I am training in, and what they're going to help us out today. So focus A and B lines. I'm not very well educated in this, but we use it for what we want. It's very focused in that sense. I learned actually more from it from Keshav, Bruce, Vijay, and of course us. And of course, what we think about it is once we get this ribs, essentially we look for whether there is a normal lung sliding, and of course if it is not. If it's not moving as much, the typical sky ocean beach is what I think it's called, sky ocean beach, in which they have the muscle tissue and of course the tissues underlying it. Yeah, this is the interface, the sky ocean beach interface which they're talking about as you're going on. And then you have a loss of it, or you have V lines, typical V lines going all the way down, three of you making a comment, etc. So when you have that, it's very clear. You can see that on the left here. You can see what we're talking about all along, where you have the entire thing going up, and when you do not have it, or when as you are treating it, it gets to improve. So V lines again, in echocardiography, this is followed in real time. You can see that it's initially there, and as the patient improves, it gets out of the series. The barcode sign what we're talking about, in which again there's an aspect of lung sliding. Though it's not very specific for pneumothorax, but it sort of gives you an idea. It could be one in the right single session. So in a nutshell, we've been talking about all of this in the afternoon session. They should show you this hands-on. But then I think in a nutshell, an echo in a cardiac shock situation gives us the diagnosis of it. It gives us how to manage the patient, point of care. Everything is point of care now because there is no point in trying to send the lab result and wait for a BNP, and being not available in other hospitals in India. So if you can do that bedside with an echo, it would be great. So in terms of what you find as you're finding here, then you can type the kind of shock that you have and then manage accordingly because some of them are really important to be diagnosed early, like tamponade, for example, pulmonary embolism, where you neutralize the patient. So echo is a critical tool in the diagnosis of shock and in decision making. It can be a detailed echo which takes minutes, more minutes than you need, but a focused echo in the ER which gives you diagnosis at that point in time and serves as an excellent radiation free tool, easily used, repetitive, and good. I'll give the slides, all the slides can be shared with the delegates, but then this is a very verbose kind of thing where they have, but then if you see at the end of it, it comes down to the actual integral rule out. Echocardiography of integral rule out CTUs. So you look at whether is it myocardial, is it aortic, is it anything else, and then you could make a diagnosis based on that. Is it a hyperdynamic kind of a shock? Is it hypovolemic shock? Is it septic shock, etc. Thanks so much, and I hope we'll have a wonderful session, a wonderful hands-on session for which I request all of you to stay for the afternoon. Thank you. I'm not going to take any questions. I'm very poor at answering them. So I have that advantage because I'm there. In any case, I just request, is Yamini around to introduce the next speaker. Thank you. The next talk will be on heart failure and reserve care, the HFF.
Good afternoon, everyone present over here. It's my pleasure to introduce Dr. Sathya Sai. Dr. Sathya Sai is presently Chief of Non-Invasive Cardiology at Narayana Institute of Cardiac Sciences, NHNC, Bengaluru. Narayana Health is one of the largest and well-known private hospitals in India. Sir has more than 3 decades of clinical experience, and his interests include clinical cardiology, non-invasive diagnostics, especially echocardiography with special interest in advanced echo and specialized echo procedures with focus on interventional echo. He is deeply involved in academic activities and has authored many chapters in cardiology books, numerous journal publications, and is involved in research projects nationally and internationally. He is regular faculty at regional, national, and international echo and cardiology conferences. He is presently President-elect of Indian Academy of Echocardiography and immediate past editor-in-chief of Journal of IAE and CBI. He is also the secretary of NH Medical Ethics Committee. Many national and international conferences on echocardiography have been organized by him. He frequently conducts echo workshops which are extremely popular across India. Sir, it's a great honor to have you with us.
Can I just request Bharwar sir to please welcome sir with a moment of love from songs. I can tell the audience one thing. Thank you so much for being here, sir. I can tell the audience one thing, and I think it holds true for all speakers. We had to really abridge their series. Many of them ran into 20 pages, 15 pages, and all. So he's one of them. He's a doyen of echocardiography. He is president-elect of the Indian Academy of Echocardiography today, and probably the most senior echocardiographer along with Bharwar sir today in the city of Bangalore. Thanks.
We sir made our job easier, sir. I appreciate it. Thank you so much for that. I know you see that.
I'm very humbled by
I don't know if that's the tip of the iceberg or what you've spoken, but
Thank you so much for the wonderful words. Very humble. Namaskar and Sairam to all of you. And it's always been a pleasure coming to this institute, and it's always been very, almost like a home when I come here. And it's been a privilege and a pleasure to listen to the speakers with their wonderful presentations and take home messages. So my task is cut out, so just a few minutes. The last chapter, so I'm quite impressive. So this again is connected to whatever has been in some way to the previous topics which I've shown earlier. So heart failure preserved ejection fraction has been a topic which was not well known about a decade back, or more of a discussion on systolic, diastolic heart failure, and so on and so forth. Over the last 10 decades or so, a lot of data is coming, so now it has got its entity and there's a lot of issues related to it. So this is something which you're all, right? So I want to slide, you're all familiar with. So this is something which I just want to stress that the preserved ejection fraction has got the same survival sort of curve like reduced ejection fraction, and these patients earlier were sort of being ignored, and but it's important that you take this message that they have the same sort of course as the reduced ejection fraction. So let us look at the definitions. So these have undergone a lot of changes with the guidelines and the most recent guidelines. So this is from the European Society of Cardiology. So they have these three categories: reduced ejection fraction, mildly reduced, and then preserved ejection fraction. So they're very clear about also the combination of symptoms and signs, and then you have ejection fraction of 50%, and then the objective, that's structural, and then you have dysfunctional, the diastolic dysfunction, the filling pressure, and then the So these sort of comprise the preserved ejection fraction. So just digress a little beyond that. So just a few mentions. So they had this mid-range which has been discarded by them. So now it is called highly reduced. And then they also use this word recovered or improved ejection fraction. So this is from the reduced ejection fraction. Now, when it comes to the ACC, there is this improved ejection fraction which is given importance here, and there is nothing more mention of the recovered ejection fraction. But when it comes to preserved ejection fraction, it's more or less the same, but the stress is more on the filling pressures, and then you have to look at the hemodynamics. So that's where ACC is. Now, what happens to these patients of preserved ejection fraction? So these are the trajectories. So like you see that they can end up becoming reduced ejection fraction, they can become mildly reduced, or they can continue to remain in the preserved ejection fraction here. So this is the one which we focus on. Now, the question is when to do this echo. So as far as the guidelines are concerned, it's very high on the list, and it is 1C, the recommendation. And when you look at the diagnostic algorithm, you can see that you start with clinical, and then you come to the AN meter, and then echo is the third one. It's very important, so it's very crucial to use this. And based on this, I'm going to prove it out, or you sort of go into this category depending on what the imaging factor. So the EF plays a big role as a number. Now, when it comes to ACC, a little more elaborate one, but the same recommendation 1C here. And here they mentioned when you're suspecting or newly diagnosed, or those who have been diagnosed or who have had a change in treatment, or who are going for some invasive blood pressures, do the echo, and a very sort of lower of the non-invasive testing. So that is the two. Diagnostic algorithm more or less the same as the ESC. Now, how do we diagnose all these patients who develop heart failure reserve ejection? It's very important that you look at the patient also. Who are these vulnerable patients, at-risk patients? So anytime you see a patient coming to you for echo who's elderly, more than 70 years, with notes mentioning that they have heart failure, especially females, those who are overweight, obese people, metabolic syndrome, diabetics, and who look very sort of deconditioned, and those who have hypertension, chronic kidney disease, AFs, and ECG abnormalities like AVH and LFH, of course, any BNP levels are there. And so these are the vulnerable patients, and you have to put an extra effort to see whether the criteria to sort of whether the fulfill reserve ejection fraction. So this is the slide. It sort of encompasses a lot of discussion about cardiovascular. It's still not a closed issue, very controversial debates, but this is the one which is taken from the latest document from the AAC in 2016. And who are these people you should be looking at? So the grading, the grade 1, so some of them may have increased field pressure, so you should not sort of assume that any grade 1 will not have it, so they are sort of less likely, but they can't really do that. But the ones you should be focusing on, once you say grade 2 or grade 3, and based on the reserve ejection fraction, so these are the numbers which you're all familiar with, which I will again focus on later. So this is where you're looking at. Now, so this is a little bit of a summary sort of slide as far as the ACC is concerned. So one is to focus on E by E prime and look at the central E velocity, lateral E velocity. Very important to look at both of those. And then again, the TR velocity. So there's a lot of focus on TR velocity. We have a tendency to sort of focus on the ESC, but the TR velocity is also something which should be included and mentioned. Of is 2.8, and of course the PSC was we want to measure is around 25. Now, the algorithm as far as the document is concerned, so this is again which has come from the Europeans, and it has been endorsed by the ACC also. And this is how the approach should be. So there is an initial workup, just looking at some basic sort of parameters, dimensions of the chambers, looking at the vascular functions. And then there is something which is favoring heart rate reserve ejection. Then you go into a more elaborate detail, do a very comprehensive echocardiography where you put strain here. And this is the time when advanced workup, so sometimes you're patients are symptomatic, but you're unable to do, then the diastolic stress just kicks in again. And beyond this point, echo has very limited role. Of course, it can provide some information, but the information is always by the other imaging tools. Now, what are the actual parameters to look at? So let's look at a patient here. So this is a typical patient. You already, and this is a very classical patient. They come in all sorts of packages. So an elderly female, breathlessness, worsening over the last few days, and then has this comorbidities and added on the CAD, and it was just minimal CAD and breathless. And these are the vitals here. And ECG, non-specific changes, but X-ray doesn't look so good. And of course, with the lung ultrasound, this is where the real role can be very helpful in these patients, and you can sort of minimize the delay in sort of looking at the findings here. And the labs, of course, they take their own time. So this is something where echo sort of comes in at this point. So a quick look at the typical sort of presentation. So you have a non-dilated LV, and then of course there's an LA dilatation. So who's pointed out in the morning, all these patients who have HPF, so they have this. And then they also have the additional structural changes in terms of LVH, where there are these cutoffs, which actually and you have to rule out valvular heart disease, and then you rule out coronary heart disease, and then of course the ejection fraction is also very important, where you have established that it's about 50. And then it's also important to look at the area volume because it's part of the diagnostic criteria. So though we don't do it on a routine basis, it's just very simple. It just takes about up to 1 minute. All you have to do is just file the pages and do it post processing. And you have this number, which again verifies the cutoff. It is increased in this patient, and then you have increased PSP or KR costs. So these are all sort of classic findings of HFpEF patient. And we come to the final one where this is sort of really sort of bridges the whole thing, vascular dysfunction there. And then you have this E velocity and then the septal and the lateral velocity measure. And then you get the feeding pressures here. And this is increased. So this is the vascular assessment. We can go one step ahead of more more detailed sort of approach. So you can look at the GLS. So this is again echocardiography. So here you can see that the GLS is low and then straight down to the circumferential process. So this software is not available commercially, so this is more software which is off the machine, but it is available in some people. So but it can be done, and here it shows that even the circumferential strain is slow. So let us look at these individual parameters what the document says. So they have divided into major criteria, minor criteria. So anyone with significant FVH, so these are the higher FVH, and also there's focus on the electric wall thickness also, just looking at the dimension and the posterior wall. And then you have minor criteria, less FVH, and then you have this wall thickness still high, and then definitely again looking into end axis wall thickness, the fast long axis, which is more than 12 millimeters. So major minor criteria. And then looking at the E by E prime. So the cutoff here again based on age 75 and then higher the age more above 75 years, the velocity is automatically drops here and we get about these cutoffs. And then again the once it is above 15, it's major criteria, and then somewhere between 9 to 14 what's called as the intermediate area, it is minor criteria. I think less than 9 definitely it is on the lows, the normal side. Volume index again you have major for sinus and then atrial fibrillation. So atrial fibrillation always will have a higher volume because they tend to have a bigger agent. So here 34 and 40, and then in sinus the minor criteria is around 29. So these are the numbers. So 29, 34, that's what we have to remember. Anything less than 29, it is common. And lastly, the PR velocity, so again 2.8 and PAC. So these are standard numbers which again so we don't re-emphasize which you all do. Now, when it comes to echo assessment, the document again is very clear. So this is something we have in that, but it's very important that you use objective way of no visual view. So as much as possible, if these patients do a very objective way, I do something since a high plane, or you can just look at the LV volumes in terms of breathing, which is more accurate. You have that. And definitely, if you do have this, and sometimes the independent model is not well sort of seen, and this sort of improves this. Now, what really sort of the approach towards it might have been so much of the talks, especially of the talk that looked at the data, they had higher death and hospitalization, and they have come to this cutoff of around 16%. So typically this is what really happens. So you have a longitudinal strain that starts to decline, sort of linearly starts going down, and then the circumferential strain starts to kick in and starts to provide the much needed support and compensate. Over a period of time, this also starts to decline, and this is what we saw in our patient earlier, so where the circumferential strain. And at this point, they start to mildly reduce, and then afterwards they get into the reduced ejection fraction, and that's when things become a little more problematic for the patient. So again, this is a combination, a compilation of the various sort of studies. So you can look at this number, which most of the clients is 16, and again, the software, more of the GE software and less in complex software now. But again, the number has been sort of around 16, that's where it cutoffs. Now, correlation with BNP also. See, higher the BNP, lower the confluence strain. So there's a linear, so there's a correlation with this also. So if you combine all of them and put them into an algorithm, a little complicated and it's very difficult to follow, but it is there. And when it comes to ambiguous patient, I think we should sort of look into this. Again, divide the function of into biomarkers here. So this is the function looking at the central and then the TR velocities here. and then the morphological is the negligible volume, and then the mass here, and then the minor criteria changes comes in here, and then have the other sort of lower values here. And then the biomarkers BNP is being told. So there is this scoring here, the criteria more than 5 points effort, and anything less than 1 effort unbalanced. So in between, when there is a patient symptomatic, but the scoring is sort of conclusive, so one can look at last stresses. So just a summary of the same thing what has been told here. So this is the basic guidelines. You can see that a lot of emphasis on the mass, the little thickness, the volume, the layer volume, and then they have a set of 9 here. So this is where the story starts, as far as the biomarkers, and then the end proBNP, and then the PSS. Yeah. And this is just a simple algorithm of those who sort of are inclusive. So we can look at the vascular stress, and then the main factor we look at is the by increasing with exercise beyond 15, and then the PR velocity also going beyond 3.4. And if this criteria is fulfilled, that means this patient has got heart failure preservation. Right? So to conclude, just a couple of slides and I'm done. And this is just to look at the various parameters. It's still a work in progress. You can see that it varies more of the specificity emphasis here. And these are again and again I'm showing this. So this is where the focus should be in E by prime, in E velocities, tissue Doppler, the mass, PSP, those classes, GLS, etc. This is how the approach to arterial preservation should be. And higher the number of markers, more likely the chance of getting raised in the calculation, and higher probability diagnosis. That's the approach that should be. So my last slide is any patient coming with breathlessness and clinical suspicion of heart failure. First and foremost, look at the vulnerable population they filled in, and then do the basic diagnostic approach, and then if it's there, go for a more comprehensive approach, and concern go into vascular systems. So you can also use the echo to rule out other sort of possible breathlessness, reduce fracture or valve stage, other causes, and other related issues. When it is very high NBM, more than 70%, high likelihood of infiltrating cardiomyopathies, of course, there will be other findings also. This again should be kept in mind as a suspicion. And one should also be aware of mimics of artificial preserving. So this is my sort of message, and thank you for your kind attention.
So we have come a long way from IPCD's original definition of what we used to call the reduced ejection, like a normal ejection fraction. It's really done away with the need of BNP, though it's speak of echo BNP. Today, the restricted slightly where it's not available in BNP and BNP. It's actually one of your take that you can completely diagnose FPF with echo.
BNP, again, you have problems with these patients because you have more highlights. So, there are certain scenarios where BNP, of course, will be helpful, it should be included, and it's part of what already have been adapted to practice. But echo as a tool is definitely sort of combined with the HEFR, and it's always sort of, it gives you a lot of informative findings, getting to diagnose, just looking at the left atrium. The size of the volume itself is enough, and then the E by reference take much time, and so in part of the doing nothing extra, you're just looking at the same thing. So it should be a, and I think the message should be that one should look at all these patterns, at least not all of them, but at least some of them.
Most of them. And so, how does it work in patients who are on RT? Because they say that people who are on ARNI, you can't use BNP as a tool. Anti-pro-BNP is so all this doesn't work well in those patients as well.
Yes, there are many studies on RTs where they have put the GLS, and then the focus has been on the LV, and where they have shown that the LVEF continues to be the same even after 3 months.
Right.
No changing here, whatever method you use. But at the end of 3 months, they have shown that the strain starts to improve. So that's the sensitivity as far as strain is concerned, and the limitations of EF. So that's where I think one can look at these arguments again, looking at the
keep on monitoring of them.
Simple tools like sphericity index, of
Right.
course, you have these volumes of green, we have to get it validated.
Right.
But the simple tools again, consider the again for the people here is that use sphericity index just looking at GL side.
Right.
Looking more.
Right.
And there's a lot of focus on the occasional strain.
That's true.
So, that's another day.
Let's talk about the hormones.
It's still.
True. Any questions from the audience? If you are not, sir, thank you so much for the talk.
Thanks.
We'll go to the next talk. If you are echoing cardiomyopathy, given by Dr. Vijay Krishnamurthy. I request you for it.
Good afternoon, everyone. Today I take this opportunity to introduce Dr. Vijay Krishnamurthy sir. He is an interventional and consultative cardiologist in the University of Rochester Medical Center in New York. He has many honors and awards to his name, including Best Fellow Teacher of the Year award in the year 2011. He is active academically, delivering many lectures at cardiac and vascular symposia. He has also been involved with 6 research projects and has 6 major national and international presentations and has several articles, publications, and abstracts in scientific journals. He has been closely associated with the Sathya Sai Institute since several years and has contributed in all possible case patients at our hospital. I would request Dr. ISR to felicitate Dr. Vijay.
Very old dear friend.
Hello everybody, slice again today. I most humble pronounce and Lord seat of our divine Lord, who's always brought all of us here for this wonderful day. I know it's almost standing between you and the lunch, so I'll try my best to be as quick as possible. My topic is echocardiography in cardiomyopathy, and I will try to focus, because I'm an interventional cardiologist, I'll try to focus on intervention part, medical intervention in the office, and also an intervention in the cath lab. I have one cool case from one of my mentors, which I thought I'll share with all of you. And also he's planning to come here, he's an expert in alcohol circulation. He really wants to come here and hoping to this be a segue when he's here, hopefully next year.
That's really great thing, sir. Actually, alcohol ablation is done in many centers in India, and it's done in our hospital also. We have a center which has done a lot of work on that, and we found a lot of different criteria, very interesting criteria in India. Just to share with you, we built an app on it last year as to what are the predictors of ventricular arrhythmias in this patient. So it was very interesting that in Indians, we found that, as a preliminary study, of course, 60-70 patients, we found that LGE doesn't need to be 50% or more in patients in Indians. As an ethnic population, at 10% and more, we used to get arrhythmias, the patients with arrhythmias. The second thing was even the GLS, for example, the nostril strain in these patients was not as worse as what was reported in literature. We used to get patients with minus 12% and below. That is more negative on the side of 12 as having arrhythmias. So as an ethnic population, I think we are at higher risk for whatever reason it is. We need more research. But then I think it will be nice to hear Vijay sir, of course, with echocardiography and cardiomyopathy.
Thank you.
Thank you, sir.
All right, so quick overview and then treatment updates for amyloidosis. The interesting thing about cardiomyopathy is our medical treatment available for amyloidosis. Earlier we used to make this exotic diagnosis, and then the patients really didn't have anything apart from even transplants. They were not candidates. So it's very small ventricle, LVADs, they were not good candidates. So then I'll share a case of transthyretin related amyloidosis and a case of overcome. Echo is of course a gateway in the diagnosis of cardiomyopathy. I think there's still a role for swan guns. I'm sorry. I don't think they're still there yet. There's a PA capital management institution, and they're very sick. It's very important. Of course, echo gives you the difference between systolic and diastolic heart failure, ischemic versus non-ischemic, and it is very helpful in managing a patient in your office. I was going to skip all this because of time constraints, but again, tafamidis is a new drug, which is an oral agent which stabilizes the transthyretin and thereby inhibits the formation of amyloid fibrils. So because of this, we are able to almost stagnate the disease progression of amyloidosis. And there was this ATTRACT study where there was a significant mortality reduction. I mean, there's not many trials in cardiology where there's a significant mortality reduction within 400 years. So this is a cool development in the field of amyloidosis. And I hope this contributes to its high Again, in hypertrophic cardiomyopathy, there's a new drug which is available in very limited clinical settings where there are places which run hypertrophic cardiomyopathy clinics, and they have started using these drugs. So our hospital, our university is one of these centers. So it's called CAMZEOS, and the hypertrophic cardiomyopathy is an actin-myosin interaction. There is a hyperinteraction, and this drug inhibits the actin-myosin interaction. So obviously, you have to follow these people with a very strict echo protocol because they can develop cardiomyopathy in low ear. So that is why it is in a very controlled setting that this drug has been released. It came out through this Explorer hypertrophic cardiomyopathy trial. So the LVOT gradient goes down, and patients have significant clinical improvement. So this having two easy treatments, oral agents with minimal side effects. Tafamidis is like almost no side effect. The only side effect is $40,000 a year. I don't know how they came up with such an expensive number for a drug, but anyway, that's how much it costs in the United States. So this patient came to me about 2 years ago, 86-year-old gentleman. He was diagnosed with some family history, hypertension, chronic kidney disease, and recently started on glyburide for diabetes. He came with 2 to 3 months of progressive dyspnea and lower extremity edema. He had 2 pulsating edema in the extremities, elevated general venous pressure. He was taking atenolol 50 milligrams for his hypertension for a long time. He was also on amlodipine 5 milligrams for a long time, so this edema was completely healed. His creatinine was 1.8. So this was echocardiography. I just want to stress how these transthyretin, you always, when you say amyloidosis, you're always looking for the starry sky, thick ventricles. It's not that. That's at least my clinical experience. They look like any other normal LVH type of ventricle. So when I was looking at his echo, I was just like another diastolic dysfunction, hypertensive heart disease, heart failure. That's kind of the approach I was taking in this case. Obviously, you can see here the left atrium is a little enlarged, and the little vasculosis. And his atrium was prominent. This actually what caught my attention. He had a significant restrictive filling. He had grade 3 filling, a diastolic dysfunction. His filling was quite restricted. So I was like, oh, what's happening here? And you can also see his diastolic relaxation time is very short. It's only 70 milliseconds, and with a very low E prime, it's overall like a E by E prime of about 25, so it's significantly volume up. And you can see when he did the global strain curve, actually he went home and I had to bring him back and make the sonographer do the strain in him. It almost had this cherry on top appearance, which is very classically described for amyloidosis, where there's a sparring of the apex. So with all this, I said, okay, I'm going to start on diuretics because he's clearly volume up. He has a restricted filling pressure. So I actually started cutting back on his beta blockers. I took him off his atenolol, put him on a very small dose of atenolol, gave him a better heart rate. He didn't need a heart rate of 60, his heart rate came up to like 80. He had a much better cardiac output. So whenever you see restricted filling, they have a very limited stroke volume. So the only way to improve cardiac output in these patients is to increase their heart rate. So this is a common thing I see. Generally, heart failure, beta blocker ACE inhibitor. These are a little different type of group. So he came back feeling much better. But looking at all his strain and everything, I told, okay, you want to get worked up for amyloidosis, there's a treatment available. He said, no, I'm fine, I'm 86, I'm already feeling so much better, I don't want anything. But of course, he went home, then his daughter called me a couple of days later and said, I think we should pursue treatment. So this is a cool thing, when you look at diastolic function on echocardiogram, that helps me manage the patient. When they are grade 1 diastolic function, of course, this doesn't hold good for heart failure visualization fraction, but still when you have grade 1 type of filling pressures, typically their left atrial pressure is normal. And once you go to grade 3, that's when you have to think of restricted filling and think of other ways of augmenting cardiac output, which may be withdrawing your beta blockers. And he did end up getting this technetium pyrophosphate SPECT scan, and you can see the heart versus the contralateral side. You compare these two, and that's how we diagnosed him with transcardiac amyloidosis. So he, unfortunately, he ended up not getting treated. He said, this is an expensive treatment, and at 86, just leave me alone. And he's doing well, actually. So this is the next case. This is a case where how important and vital echocardiogram is in a cath lab when you're doing an alcoholic septal ablation. Of course, it's a thoracic echocardiogram. So this is a 54-year-old female. She has hypertrophic obstructive cardiomyopathy, and she had an ICD for non-sustained VT, no history of syncope or shocks, and mild non-obstructive coronary disease. She had class 3 angina and dyspnea, and she was brought into an echocardiogram. And this is a classic echo. You can already see there is a significant septal hypertrophy. There is a scar of SAM, and you can see there's this solid closure of the aortic valve, and then you can also appreciate some MAC and significant left atrial notch, which speed the theme of most of the day. You can see flow acceleration and also SAM passing the mitral regurgitation. So this is a gradient we got. Now, I mean, obviously the aortic valve was functioning really well. We know that this is not aortic stenosis, but how do you got to make sure that there is the mitral regurgitation is not measured appropriately. So one of the best ways to look at this is the isovolume contraction time and isovolume relaxation time. Once when you see these two are preserved, then you know that this is a true sampling of the LVOT. In a mitral regurg, you will not see that. So this is a very important clinical call. I use it all the time because the sonographer sometimes they can just a little tilt will be on the mitral regurg. So we decided to proceed with alcohol septal ablation in this patient. And so she had dual arterial cannulation. We have one catheter in the left ventricle, one in the coronary, and we have an echocardiogram to help define the segment, the septal branch which we need to inject alcohol into and ablate the septum. So there are obviously, all of you know, there are so many septal branches. We need to choose the most appropriate septal branch. So our way to define the target is to inject opticin, or which is the echo contrast. You can use definitely opticin, about 0.1 cc diluted. You go find the septal branch which you want to treat, occlude it to the balloon. Depending on the size of the septal branch, it's a 1.5 cc or 2 cc balloon. Occlude it and then inject contrast and see what happens with echocardiogram. So this is a classic example. This is a patient we have here, and you can see the pre-procedure hemodynamics, and you can see this. So this was true. We were doubting were they sampling the MR or were they sampling this is in the cath lab, and you can see there is clearly the left ventricle is able to generate pressures up to 300, 350 sometimes in the cath lab. You'll be surprised how strong your left ventricle can be. And this is a clear cut, and this is a broken bro sign. So maybe during the break, if you have questions on all these, you can ask. So this is cool. These are all very cool hemodynamics. So here in this patient, she really didn't have much proximal septal branch. The first big septal branch you see is at the diagonal. And so we go ahead and cannulate it and balloon occlude it, and then now you inject it definitely. And with echo contrast, you can see that there is staining of the yes. There is staining And this is what typically happens. It stains the moderator band first, and then there is staining of the mid septum, but the basal septum is actually not getting stained with your oxygen. So we were like, okay, what should we do? So we go ahead and cannulate one of the smaller branches of this branch, and there is immediate drop in the LVOT gradient from almost 200, it dropped to 64. So we said, okay, this branch seems to be doing something. So let's go ahead and inject some alcohol. So there was alcohol injected, and as you can see, there is staining there at the mid septum, but still the basal septum is still not fully staining. So, but because there was significant drop in the LVOT gradient, we ended up going and injecting alcohol there, and as this was the end result. So the LVOT gradient was not gone, but significantly reduced from almost 200 to about 50 millimeters of mercury. So we said we'll stop here, and you can see how there's like a chunk of this is during follow-up. There's a little bite out here, but still the basal septum is very prominent. So okay, so that septal branch didn't work. So there could be many times a branch from the ramus or even from your PDA, right side of PDA. So we take her back to the lab to study her, and so this time what we did was just to make sure that we are in the right band. We injected about same 0.1 cc of cortisone into the entire right coronary artery, and with that there was significant filling of the basal septum. You can see the basal septum highlights here. We just injected the entire right coronary artery, so we knew we were into something. So now when you do the right coronary angiogram, there are like so many septal branches, and so we start with the guess. So we said, okay, let's start with the third perforator, septal perforator, and with that we didn't have much. Then we went back again to the second septal perforator, and now you can see there is a beautiful staining of the basal septum. So it was actually from the PDA that the patient was getting a septal branch supplying the basal septum. So we ended up injecting alcohol into that, and with that we have a beautiful result where the gradients are completely gone. So this is the end result of the patient. So this is echo is absolutely vital when you plan and treat patients with hypertrophic cardiomyopathy, especially alcohol supplementation procedure. And this is a new change in our algorithm where we started injecting oxygen into the left main or right coronary artery non-selectively, make sure we are in the right vessel, and then go selectively each branch and then confirm our target branch and then inject. So again, in conclusion, echocardiogram is vital. It's a gateway, but not only a gateway, it's a friend in need till the end of your treatment of these patients of hypertrophic cardiomyopathy or amyloidosis. They just help you throughout the way, managing your diuretics to beta blockers to alcohol supplementation. Thank you. Thank you again, everybody.
Are there any questions for Dr. Vijay? If not, we'll go ahead to the next talk. This will be a talk on RV function assessment as of what we know of it today, 2022. This will be given by Dr. Sunil Bora, a very good friend of mine and a very, very good echocardiographer and lawyer again in the field of echo. I request Shirisha to introduce. After this talk, we'll break for lunch. We'll have the next talk, after the lunch, and then we'll have the hands-on session.
I feel very happy to introduce Dr. Sunil Bora. Dr. Sunil Bora obtained his MBBS degree from the Bangalore University and did his post-graduation in internal medicine at St. Martha's Hospital, Bangalore. He holds a fellowship in non-invasive cardiology from Rajiv Gandhi University of Health Sciences and a fellowship in diabetology from MV Diabetes Center. Currently, Sir works at Hospital as the Chief of Internal Medicine and Cardiodiabetology.
Previously, has been the head of non-invasive cardiology at Watersource Hospital. He has been an EC member of National IAE and has been actively involved in imparting echocardiography education. His special interests include basic as well as advanced echo. He is a regular faculty and speaker at various state and national level echo and cardiology conferences and workshops. He is a member of various societies and was the assistant editor, Journal of Indian Academy of Echocardiography and CBI. Sir has been awarded with the prestigious fellowship of IAE and was organizing secretary for the National Conference of IAE Echo India 2021. Now, may I request Dr. Barawasa to felicitate Dr. Sunil Gora.
Cycle?
Sorry for that.
There it is. It's there. It's coming. Just, yeah, come on. It's coming. Just, yeah. Yes.
I was standing between you and the lunch, so I tried to understand. So I would like to thank the team from Sathya Sai for inviting me, especially Dr. Babu, Dr. Rita, and Dr. Ram. So it's always a pleasure to be associated with Sathya Sai. Before I actually commence my talk, poem by one of my teacher, Dr. Prakash, the right ventricle dynamic. Will someone kindly tell me, that's what the right ventricle is saying. Will someone kindly tell me why I ignore always, why my big brother LB gets adoration and praise? Is it because I function rather slowly with the lower measure in the VA that I am considered to be lazy and set aside by the high and mighty? Even when I flatter an infarct, they call it inferior MI. Till wisdom dawns and in fact they find that it is a poor army. They do concede, I win my war. When the giving fates, I have been dilated. But why does he say trivial PR? That truly gets me agitated. Here's wishing the hard dogs are kind and see me in my true light and glory. He who ignores me and is unkind may often end as a sad story. Thank you for Dr. Prakash sharing this with me. So my talk is based on these guidelines, which are all free available to go through this guidelines. Echocardiography assessment of right heart incidents published in case 2020. And there's another article published in March 25. And also the state one guidelines. So the RB, the physiological importance of RB has always been underestimated. It was considered mainly as a compute, whereas its conductive performance was thought to be inherently unimportant. But we know the primary RB functions are to meet an adequate pulmonary pressure, the varying circulatory and loading conditions in order to deliver desaturated venous blood to the gas exchange components of the lungs, and also to maintain a low systemic venous pressure to prevent the lesion or organ congestion. So the normal RB is a complex crescent shaped structure which is wrapped around the LV. It's composed of three distinct portions: the supramuscular inflow portion, the outflow region, and then the gravitated apical region. The right coronary artery is the primary value supply of the artery via the various marginal branches. So coming to the nomenclature, so basically the artery has the four walls: the anterior, the inferior, the lateral, and then the RBOT wall. So these are basically divided based on their blood supply. The inferior wall of the artery is supplied by the posterior descending artery of the right coronary artery. The anterior and the lateral branches are supplied by walls are supplied by the acute marginal branch. And then the RCA, the cornus branch supplies the RBOT. Part of the moderator fan and the septum is supplied by the gate. So how do we study the RB? There are various views, almost there are 14 views which we can look at to study the RB. I'm not going to the details of each one of them, it's all given in the guidelines. But it's very, very important to look at all these views, be the horizontal long axis view, the RB inflow view, the RB outflow view, the short axis views at various levels, the four-chamber views, the five-chamber views, and also modified views, the February sinus view, and going to the subpostal long axis and the short axis. I'm not going into the details of what all has to be seen. It's all there in the guidelines. We move on to the echocardiographic assessment of the RB size. The RB linear dimensions can be measured from the coaching will be obtained from medical report. And so you have to make sure that you attempt to adjust the apical coaching to acquire the right apical focus view, which is very, very important because all the measurements will depend on that. So the linear dimensions, basal, mid cavity, RB, diameters, and the RB longitudinal dimensions are measured from these views. Mid cavity diameter is measured in the middle of the right ventricle and the level of the LV capillary muscle. The normal range is RV basal diameter will be 25 to 41 millimeters, RV mid cavity diameter will be 19 to 35 millimeters, and RV longitudinal diameter 59 to 83 millimeters. We need to remember all these numbers. Coming to the short axis, the RBOT dimensions, it includes the supplementary infradental motor bonus and the pulmonary valve. In the normal reference range for the Knox view is 30 millimeters, and in the short axis view, the proximal will be 35, and then the distal measurement is 27 millimeters. The RV wall thickness is a useful measurement for looking at RVH, usually the result of RV systolic pressure window. It is measured at the end diastole by MO or fully subposite window at the level of the tip of the anterior periscopic plate, and even the proximal windows. The normal wall thickness is 3 to 5 millimeters. So to summarize the measurements, we need to look at the RV basal diameter, the mid diameter, the longitudinal diameter, the RVOT diameter, the transview, and then the short axis view, and then the RV wall thickness. So this is the measurements of the RV. Coming to the assessment of the RV function, we need to assess these by one or combination of the following. We can look at the RV index of myocardial performance, the RV dP by dt, the fractional change, 3D RVEF, the DAPC, then tissue Doppler derived measurements, and then we can look at the same. So we go one by one with each of these measurements. Going to the T index, it can be measured either by the pulse rate Doppler or by tissue Doppler. By pulse rate Doppler, we have to take two measurements. One is at angle or portion, we need to look at the pulse rate Doppler across the tricuspid gland, and another we have to take in the short axis view at the level of the pulmonary gland. And how you calculate? We calculate by looking at the tricuspid valve closure to opening line, and we minus it with the ejection time and divide by the ejection time. The reference range is 0.1 to 0.3, and if it's anything above 0.4, it is considered abnormal. So the advantages of this measurement is it has a lot of prognostic value if you do it in single patient family comes of follow, and it is less affected by the heart rate. But the limitations are it requires matching for RR intervals and measure because measurements are performed in different recordings, and it is unreliable when the RA pressure is elevated. By tissue Doppler, again, it's very, very easy. We need to just take the sample volume and the lateral tricuspid annulus and take this tissue Doppler, and the calculation is done by this formula IV RT plus IVCD divided by the ejection time, which is same as the right tricuspid closure to opening time minus ejection time divided by the ejection time. So the normal reference range is 0.3 to 0.4, and if it's anything above 0.5, it is considered abnormal. So the advantages of this is it is less affected by the heart rate, and it is a single beat recording with no need of RR equivalent conversion. Limitations it is unreliable when the RA pressure is elevated. Coming to the RV dP by dt, it's again very useful. It is estimated from the resting name of the tricuspid regurgitation continuous rate of the Doppler signal. Is calculated by measuring the time required for the tricuspid regurgitation plane to increase from the velocity from 1 meters to 2 meters. And it is calculated by this formula that is 12 millimeters of mercury divided by the time in seconds which we gave this. So any value less than 400 millimeters of mercury per second is considered abnormal. Again, the fractional area change is again very, very important, useful measure. We can look at this by tracing the echocardiography bottom, the RV in diastole and systole, and we can calculate the fractional area change. Anything less than 35% is considered abnormal. Advantages of this is it is a very established prognostic value. It reflects both longitudinal and radial components of the RV contraction, and it correlates well with the RVEM by cardiac MR. Limitation it neglects the contribution of RV outflow tract to the overall systolic function, and has a very early affair into the absolute period very reducibility. Coming to 2D volume assessment, it is not recommended because of a lot of heterogeneous methods, and then there are numerous geometric resolutions, usually don't do a 2D volume. The 3D volume is definitely very, very important, and the upcoming thing whenever the machine you have, it's feasible to do that. The advantages is it includes the RV output tracks contribution to the overall function. Correlates well with the RVEL by cardiac MR. There are a lot of limitations, but then this can be overcome because it requires a lot of offline analysis, which can be done in few centers of where it is available. And the longitudinal systolic assessment by TAPC is very well practiced, and it's very, very important to do this at least in all the patients because it is available in all the machines. Advantages, it has a very established prognostic value, it is validated against radionuclide estimation. Limitation is angle dependent, which can be overcome by doing the proper assessment. And it is only partially representative of the RV fluid function. Anything less than 70 millimeters is considered abnormal. We can use tissue Doppler S-wave, tissue Doppler S-wave velocity. Anything less than 9.5 is considered abnormal. So again, it is very easy to perform, it is reproducible, it is validated, and has very established prognostic value. Again, the limitation being angle dependency. So we need to be taking it in a proper way. Again, the S-band, the color issue of the S-wave is same as the issue of the, but it has advantages that it allows multiple sites something on the same way, and it can be done offline. There are a lot of limitations with this, and anything less than 6 centimeters per second is considered abnormal. So the RV systolic function assessment by screen imaging, again, it is an upcoming field and has very established prognostic value that is not there in other issues, but then wherever it's possible, we can do this. The longitudinal strain assessment is regulated by specific systolic shortening of the RV fever on base statics. The global longitudinal RV fever strain and anything less than it is more than minus 20 degrees or in numerical numbers it is less than 20, then it is considered abnormal. So either we can do a free ball assessment or a complete septum and free ball assessment. Coming to diastolic function assessment, the measurement of this is done in patients who are suspected to have RV impairment. This is a marker of early or subtle artery dysfunction, and also in patients with known RV impairment as a marker of poor prognosis. So here we look at the tricuspid EVA ratio, the EVA time ratio, and then the RE size, which have most validated and preferred measurements. So how do we grade the RV diastolic dysfunction? We look at the tricuspid EVA ratio, which is anything if it is less than 0.8, it's just impaired relaxation. And if it is more than 0.8 to 2.1, with an EVA time ratio of more than 6, or a diastolic flow predominance and hepatic basis is the normal failing. And any ratio of more than 2.1 with a distillation time of less than 1 millimeters, it's a disorder. So to summarize all these, what I have told, we need to look at all these things. The most important what we do in field practice is SAPC and the issue of the S-wave velocity. The RV fractional area change can be looked at in particular patients. RV freewall police strain can be done, and there is definitely a role of RV PDA EF estimation and also look at the diastolic dysfunction. Coming to the measurement of RV systolic pressure, tricuspid regurgitation diagnostic is used, and simplified Bernoulli equation can be used to calculate the systolic pressure. And the normal resting values, the regurgitation velocity less than 2.8, or RV peak systolic pressure less than 35 is considered normal. So when we look at the RV overload, there are two types: the pressure overload and the volume overload. Pressure load, as we see in common economy within permanent also, we need to look at the circle flattening, which is persistent. And in RV volume overload, as in case of VAPC or AHD, we can look at a very subtle finding wherein there has to be diastolic circle flattening. So when we compare the pressure overload and the volume overload, persistent septal distortion throughout the cardiac cycle process, only a diastolic circle flattening helps us in differentiating the cause of the overload. Coming to the measurement of pulmonary pressure, it is very important. We do it in all the patients. And Doppler assessment is very easy. We just have to look at the tricuspid band velocity. And here the point of caution is we have to use the maximum velocity in whichever view we are getting. And we need to calculate the RF pressure and use the Bernoulli equation to calculate the pulmonary systolic pressure. How do we do it? We take the tricuspid valve, the regurgitation continuous rate velocity, and then we calculate the RA pressure. I think this where we already here, I am not doing the details of the time. But the important thing is mean pulmonary artery pressure can be calculated by this formula 0.61 into the systolic pulmonary artery pressure plus 2 millimeters on mercury. So a systolic pulmonary artery pressure of 40 millimeters typically implies a mean pulmonary artery pressure of more than 25, which is definition for pulmonary hypertension. And again, we can use the VR jet velocity to calculate the mean and the end diastolic pressures. So the diastolic PA pressure can be calculated by the PR and the diastolic pressure gradient plus the RA pressure. And when we take the peak velocity, it can give us the mean pulmonary artery pressure. The grading of the severity of pulmonary hypertension, we can do it by using this solely diastolic pressure. The most commonly used by the mean pulmonary pressure. Anything more than 30 is mild, more than 40 is moderate, 50 severe, and more than 60 is severe. So in patients whom we don't get a good ER or it's very difficult to get an ER, we can use this calculate RV pressure when there is presence of shunts, whether it's VSG or PA. It's very simple. I think the phone doctors should know this. In presence of VSG, we can calculate RV systolic pressure by subtracting the VSG peak gradient from the systolic blood pressure. Similarly, when we have a PDA, we can calculate the RV systolic pressure by subtracting the PDA peak gradient from the systolic blood pressure. My next two slides are on very rare disease which we need to be aware and it is very useful whenever it is present. So these are called as complementary indices. So one of them is the pulmonary flow acceleration time, which is defined as the time interval from the onset of the forward flow in the pulmonary artery to the peak velocity of this flow. And it is demonstrated that it is inversely related to the systolic and mean pulmonary artery pressure. So how it is calculated by this formula 90 minus 0.62 into the pulmonary acceleration time of the artery. So it's very easy to do, but we need to be aware of it and then take it so that we get useful. Another complementary indice is the mid-systolic notching, which can also indicate the pulmonary hypertension. The presence of this mid-systolic notching is very highly sensitive and specific for pulmonary vascular disease, which is characterized by a kind of high pulmonary vascular resistance, low pulmonary compliance, and advanced RV dysfunction. The absence of this Doppler notching typically signifies that pulmonary hypertension is on the left heart position, the absence of significant pulmonary vascular disease. Other supportive echocardiography findings, we should always keep an open eye and look at all these things. Like whenever we will get focused echo on the bedside, if you see a dilated pulmonary artery which is greater than the caliber of the iota, we always have to look at the artery pathology. Any RA dilatation with the distinction and rounding of the RA, any RP dilatation and RP to NA ratio of more than 0.6. The portion review which should ignite your thoughts and look at the RV pathology. Bulging of the septum into the LV cavity causing diastolic dysfunction is very easy to put it in focus echo. And versus at least typical ER, that is almost universal and it increases with the severity of the pulmonary. We need to keep all these things in mind. Additional helper measurements whenever we are doing a focused echo. We always have to go one step ahead, and if you are not able to get good Doppler tracings, be it tricuspid regurgitation or pulmonary regurgitation, you can look at these subsequent findings. Systolic velocity of the tissue Doppler is less than 12 centimeters, and then the VTX. We just have to trace this, and if the VTX is less than 2.5, it is very highly sensitive of elevated pulmonary systolic pressure. And good opportunity, this measurement cannot accurately quantify the pulmonary artery pressure, but you can just tell that there is elevated PA. Right ventricular isotopic relaxation time again is very subtle finding. If IVRT of more than 75, then it predicts pulmonary hypertension, while an IVRT of less than 40 milliseconds it has a very high negative predictive value for pulmonary hypertension. T-index, I already told about this, not going into details. So, just the last two slides. So, whenever we are looking at a patient with RV pathology, we need to see if there is RV pressure overload or volume overload. All these things are already told. We need to keep an open mind and look at all these findings. And very subtle findings, look at the pulmonary signs, look at the IVC, see if there is any presence of pericardial effusion. And always try and do a peak index, find out the RV dysfunction. The last slide, how do I report? So whenever you have all these findings, you have to look at the right heart parameters in practice. You have to report clinical background in which you are doing the study, assess the RV function by any of the means possible, but then more the better. We have more findings and more values in your report, it gives more value. Quantify the TR severity, the RA signs, the IVC indices, quantify the PA pressure, mention of the systolic, diastolic, anatomy, cardiac pressure. But definitely don't forget about that.
Dr. Goda, it showed a very nice up-to-date presentation. I just want to add one thing. Those who are doing DSC, if you do TAPSI before and at the end of, peak of the DSC, if you see TAPSI decreases by 4 points, that means that 90% proximal obstruction in TAPSI is given in UP and guideline and DSC. Very useful information. Because at the time DSC we do for coronary artery disease in IBD. So if you find this, that 4-point drop in TAPSI at the peak DSC, significant proximal artery.
Yes.
Thank you.
So the other thing was RA function dysfunction now in TAV. I think that's taking a real, in patients who are undergoing TAV, if there is a subtle RA dysfunction, they tend to do poorly as compared to. Yes, LVADs. And RVADs have come out. Any other questions from the audience? We can add to the RV's lament. Let's add to the RV's lament here. Just before lunch, they kept my talk, and I request to take a small walk. Let's just add to that poetry. I request all of you to just join us for a photograph session, following which there will be lunch. I'm sure we won't have photographs in too long. Then we'll join for lunch and then we'll regroup. Thank you so much for the talk. We regroup, we have the delegates, we have 2 talks, just 2 talks after that, after Balwa sir's talk and the Rita man's talk, after which we'll have the hands-on session. We'll tell all the delegates about their respective teams for the hands-on session after we regroup. Can we just join for lunch outside on the dome area? We actually join for the photo, and the lunch will be served on the opposite side of the corridor in the cardiac room. Thank you. I have my team which can guide you. All of you please guide the delegates.
A warm good afternoon. I'm delighted to introduce Dr. Ranjit Baroa. Sir is certified by the American Board of Internal Medicine in Internal Medicine and Cardiovascular Diseases. So is a clinical instructor of medicine in Department of Cardiology, Rutgers University, New Jersey. In the US, Sir had private practice of invasive and non-invasive cardiology in Selma, Alabama between 1986 and 1995. He opened the Selma Cardiology Center at the University of Alabama in July 1995. So was assistant professor in the Department of Cardiology and Family Practice of the University of Alabama, Birmingham. Prior to this, Sir was chairman of the Department of Medicine at Selma Medical Center Hospital. So was the chief of non-invasive laboratory, Echo Lab, and cardiac catheterization laboratory of Selma Medical Center, Alabama. Later, after returning India, Sir has been full-time honorary consultant in cardiology and medicine since 1997. Since the last 22 years, Sir has been serving as honorary senior consultant in Department of Cardiology at Sathya Sai Hospital in both invasive and non-invasive cardiology. May I now request Dr. Iyer Sir to please bestow Dr. Baroa. Thank you.
One of the greatest honor given to me.
I would request, delegates, if possible, at least in the earlier part of this talk to make it interactive, so that everybody comes out of their postprandial hyperglycemia.
Postprandial cerebral dysfunction.
Right.
Pranam, the speaker, when we first came, some used to say, my life, my message. Later on, we say, if you follow this principle, all of you, then your life will be my message. With that, some interesting echoes that I collected from our Echo Lab. Most of these are done by our Echo people, and really interesting cases that we see almost every day. All these cases are within the last month or maybe maximum 6 months. This is a young man, 20-year-old, resistant COVID, 6 months back, at dyspnea for a couple of years, and he had some chest pain, and he was, for the initial echo showed IBS hypertrophy, which is typical of HOCM.
Shown only this, what would be your diagnosis? Everybody.
If you look at the four-chamber view, there's something in the RV.
That's the reason I asked. You have to see all the images in echo always.
Okay, so here it gives the diagnosis. There is a subventricular cirrhosis. The gradient of 130 RVP gradient. So in HOCM, you are explaining all the symptoms because it is a big LV obstruction, which is gradient of RV at 35. So you are sent for surgery for the RVP, which is transit. I think here last probably more mitral stenosis than anyone in India. I would say at least 20,000 mitral stenosis have come here. But never seen endocarditis of mitral valve. So this is the case with calcific mitral valve and fibrotic aortic valve, and there appears to be a mobile mass attached to the aortic valve as well as part of the anterior third of the mitral valve. You can see some views look like it is restricted to aortic valve, but on closer inspection on all the views, you will see this looks like there is one more vegetation on the calcific mitral valve.
So it is caused by the event from the AML.
Yes, it was.
Right from the AML.
Mics.
I think there is a vent on the AML, sir.
Yeah, it's a calcific mitral valve, severe MS. So after 6 weeks of treatment, you'll be referred to surgery. This is another interesting case. Was mild symptoms of dyspnea, no chest pain, and routine sort of echo. There is a mass in the aortic valve. There was no AS for the aortic regurgitation. So anybody can guess what is it?
Please take it up. What kind of masses come on the aortic valve?
Yeah, no fever, no history of fever.
Could it be a papillary fibroelastoma? Anybody? Anyone wants to take a chance here? You have to make it interactive, otherwise, it doesn't become interesting.
So there are a lot of studies of papillary fibrillosoma from 2020, 162 cases. They have described this enormous mass both above and below the aortic leaflet. Even the book says digital below the leaflet. So there are large series of cases. They have shown that most of the time in mitral valve, fibrillosoma will be toward the atrial side, and in aortic valve, it can be both above and below. Majority of the cases are above the leaflet. It can happen anywhere in the ventricle, all the valves. Even it has been described by Renu Birmani and that's for the autopsy series that there are prosthetic valve, post-prosthetic valve, they have found papillary fibrillosoma in the aortic valve. But what to do with this diagnosis? Generally, what the recommendation is, you do not do anything because the risk of damage to the aortic valve, we may have to end up doing AVR because it's a very slow growing tumor. Unless it causes some symptoms, it can cause sudden death, it can cause TIA, it can cause mitral infarction. So, usually recommendation is give them antiplatelet. And if, however, there are complications, then of course we'll have to try to remove this. And sometimes it may not be difficult, easy to remove this, they have to do AVR. So generally surgeons are very reluctant to cast fibrillosoma of the aortic valve. Recently we had a patient who went for CMEG, we told them there is a fibrillosoma. They did not remove it. This is not causing any problem, they used to go. I believe this is the still is we can take. So if you see carefully, this is a 10-year-old child with heart murmur arterioscopy. After months, child has been little short of breath, 10-year-old child, and he is restricting his activity, staying home, and he was found to have a did he wake up?
Anyone wants to take it up? Okay, something out which is coming out at this age. Would you call it an RSOB? Does it go with the diagnosis of the clinical history which sir has given? Would that be a rupture sinus of Valsalva? Would you call it that? Anybody? Anyone can take it up. Chandrakala. If nobody picks up, then I'm going to call out people. At least the names I know. So would you diagnose this as a RSOB? RSOBA.
And 10-year-old.
10-year-old. So there's a definite defect there. You agree with that? It's like a windsaw.
And causing some obstruction to RBOP.
So what about that thing that's floating in the RB? See, you have a defect there, right? At the right sinus. If you see it above that, there's something which is open up there. At 12 o'clock or 1 o'clock there. So what is that? Sir? So that's what, sir. So would we diagnose this in this child, a 10-year-old, as an RSOB?
Insert can open and it can cause RBO obstruction.
Correct. But is this the age for the RSOB really? That's what
We have had young patients. Not many, but we have, even I used to believe that cannot occur, no? But then finally we ended up with.
So it's very rare actually. I mean, textbook if you read it, the median age is 33.
Third decade.
So this is a series of RSOB from Taiwan, not Taiwan, Chinese. They report large children cases. Youngest child of 10 years old. None below 10 years. And child was operated and found to have a small BSD also. So they closed the BSD and operated the RSOB.
Most of the time, what is happening is that what we have seen is it starts off as a pulmonary PSD, RCC prolapse occurs, and maybe because of eventually affect the RCC, the prolapse RCC becomes thins out and balloons out, and then it ruptures. That's what the two cases which our Manam operated there, they were like.
Yeah, apparently RSOB is more common, 5 times more common for in Asian population compared to Western.
Which cusp of the RSOB is not known, any of the doctors? Very rare. The left side, usually.
It can also into MV. There will get only diastolic number, no systolic number. We asked this in the exam. RSOB will be diastolic number. Systolic pressure will be same, no MV there. Diastolic number. So most of the time, RSOB will be plus number. It ranges to RA, RV. Okay, this is a 22-year-old lady. Given 3 children, she had 3 children, and now she has some little difficulty in breathing. And she has full clubbing and cyanosis. 23-year-old, whatever she is very healthy. You know marker. So what is the absent definition? Its placement, the drugs and all, 8 millimeter per square meter in the surface area. Okay, so
How do you decide what based on what? Saller-Meyer and what other score is that? Goes. Great Ormond Street evaluation.
Yeah, versus score. Then Cardiovascular score. So this patient, Sathya score of some 0.8. We have referred to certain. I think they're planning to do 20 there. This is another millimeter. LGIs RV, ATM divided by the LA, LV, and RV. Anybody wants to tell what this is? Is anyone here who gone to the Harvard and came to us?
Anyone who take it up, please?
You see there is a flow in the RA on your left. So it is a classic aorta RA tunnel. So it is not a coronary diagnosis system. Why? It's nothing to do with the coronary. It is much away from the RCA. But we have tried to put a device close this. However, the device maintains on their right coronary. So we draw this one and for surgery.
And tunnels are extra cardiac. You should know that. It's not coming from the vessel to the chamber. That's what sir is saying. It's not a coronary cameral, but in any case, if there's a vessel coming into the chamber, that would be like an RSOB. Then why is it not aorta RA, aortic to the RA, this thing, SOB rupture? Because the tunnel comes extra cardiac. You could see that in the way it was taken in the first image.
Actually, Dr. Rita and Dr. Claire, the device on this, it was nice to flow, there was no leak. But however, it's a diagnostic illusion. So immediately it was withdrawn. RCA was
Very close to the sinus the RCA ostium. So we had to pull back the device. Lekshan.
Okay, anybody want to take this? It's a very historical importance. The left atrium, you see there is a membrane across, called port trichum, which is of historical interest on the fact that first case of pulmonary hypertension in a general fellow, that's taken in autopsy, 20-year-old young man, right? And Prague, and his wife, Sarah, in 1928. It is the only case the schedule for an autopsy series. Pulmonary hypertension can occur in presence of pathology fellow. In this case, because of the border which acts like mitral stenosis. They happen to be ASD also.
It goes under the classification called Lucas. Those who are interested, a Lucas classification. You should know where it opens up, which ASD opens up proximal distal.
You see the membrane across and the flow. This kind of cases you see only in cells. Now we saw membrane on the left atrium. Now there is a membrane on the right atrium, which most people have not seen in their life. But we see once in a while. So this is called port trichum dexter, crossing ankle, the right atrium. So station valve and this membrane develop same time and biologically. But a station valve will be drawn away from the IS, whereas this membrane acts as a valve in the RA, across the RA, which remains connected to the atrial septum.
It spans the entire thing. That's what sir is saying. It's not free. Otherwise, one would miss it for a eustachian valve. The other end of it would be floating. When we got this case, we actually called sir on a Monday, on a Sunday, I still remember. We called actually Barwa sir. Then he told us the way to differentiate is it touches both the ends. Otherwise, one would miss it for a eustachian. But you can see that it touches, spans the entire array. And until an AC there at the back. Then, which opens up and then sir separately opens the other one. Sorry.
Actually, we have various calls went to our head that time. Whether you can puncture this,
Correct.
make a bigger hole, they will than I did. But the ASD is also there. So we can, for the interest of the patient, go for surgery, they can take care of the both.
It was obstructive, and the patient actually, it's a very interesting case because his saturation is on the lower side because there was an obstruction on this side, and the blood was shunting across the HD to the LA. So the surgeons removed that along with the HD closure.
Okay.
Anyone?
Mix up.
Huh?
Hello, mix up.
How do you know? Okay, so industry knows how it is. It is not compass. So I think between two fraternity and our hospital, they offered something like 800 mixers last 20 years. And one of the highest numbers in the world. Largest in the world. Largest. So this is not like that we see once a year. What I am showing you from last 1 month. Okay, next will be a little more interesting now. Now, who wants to take up this one?
Come on.
Come on, somebody take up.
It is very easy. Now go ahead.
Again, question comes, is it compass or something else? If you look at the left ventricle, nicely contracting, there is no mechanical area. So that tells us very unlikely to be a problem. So it's a very rare myxoma. It's very rare. Most of the myxomas, 75% occur in left atrium. About 2.2 to 2.5% can occur in left ventricle. It will describe. So patient is waiting for surgery now. You will notice other plastic once he goes for
So
surgery.
you want to know anything about the patient other than that? What sir said? Would you want to know if you had this thing? Would you want to know anything if sir asks you what is this? Would you want to know the age of the patient? Does it make a difference? It's not what I'm saying what it is, but supposing it's a rhabdomyoma, it's not because it's not sessile, but if it were, how would it change your management?
Suppose it's a 6-month child, you can change the mother.
How would it change your management? You would do nothing. Correct?
You do nothing. Some people take steroid, but it is no role actually. To resolve on its own, to come from use. As long as there is no PIA or red fungus formation. Okay, somebody wants to take this one? The aorta and pulmonary artery. Escape. No, okay. The right direction of sun, the aorta, in the left hand side, pulmonary artery in the right hand side. What is the age of this child? 10-month child. Salary. There's no murmurs. Usually who describe in early 18 months, may have a correctness order, but they go into accidental very soon. Because pulmonary artery are shared the same pressure. So they have to be operated 6 months to 8 months of age. Child is already 10 months old. So this is the problem at our hospital. If you come at the end and nobody else can do anything, then they
Why is it not a truncus? Why is it not a truncus? Echo technicians tell us, sir, what diagnosis it's written there. If you I say it's a truncus, why am I wrong or right? How many valves are there in AP window? How many valves are there in a truncus?
How many types are there? Whose name?
How many types of AP window are there and whose name does the classification go by?
Modes.
How many types?
Please tell us about it.
So, type 1 is proximal, where the pulmonary artery is connected to the aorta. And type 2 is distal, and type 3 is there is absence of the septum. Almost like the
This is a subtle view. You can see it below.
What one more? Richardson classification. Surgery.
The right hand side is subcostal. Okay, who wants to take up this one? Right hand side, the lateral valve. Left, lateral valve. Inhale. Yeah. What is that on the left hand side? There is a shunt from the left ventricle to right ventricle. That is called carbonated effect. How many types are there? Carbonated effect. Who knows?
How many types of gerboard are there? Anybody?
There are 3 types.
At least 2. When you say types.
We asked them in the exam. So even if these bicycle, we never do this. They have to send for surgery. The left air is also there. So they can repair the metal valve as well as close the carotid and base the partial aortic. Okay, anyone of you have seen KD? What is KD?
KD.
This is a 5-year-old child. We have been following last 2 years. But 2 years back, child had a KD. Yes, Kawasaki. And developed ordinary aneurysm on the left side. Went up 26 millimeter. I remember correctly. We are following now, it is coming down to 50 millimeter. Of course, child received globally steroid aspirin. We are giving aspirin. Okay, now this is the last phase.
Someone has to describe this completely.
Who wants to take up this? I'll tell you the history.
No, sir. No, sir. Let them pick them up. Let them pick them up.
She's a 42-year-old lady.
Okay.
42-year-old lady. She had 2 children. At 6 months, suddenly she was not feeling well. That is her complaint.
I can tell you this history is completely incompatible with any textbook history of this.
Serpentine BSD, sir.
Look at it correctly. Look where the multiple jets are. Is it in the VSD or is it in the septum? Why is the second one not paying?
Why having the multiple? Why is that area coded?
Second one is not. In any case, you just need the one on the left to make a diagnosis.
So what is the differential here? Alpha. Alpha. So small child, after 5 years, 4 years, we may see the alpha left already coming from the pulmonary artery on the short axis tube. But this 42-year-old lady, we could not visualize the alpha. But there is indirect evidence, there is vital registration there. And hypocrisy, anterolateral pectoral muscle, will be dilated, MR is there, and there will QM is AVL. So we confirmed this with a CT coronary and showed alpha left coronary coming from the pulmonary artery and so completely operated. This is our usual presentation of patients. But usually most of the corporate hospital or private hospital, it's the usual story. I think 90% of these are only last month. Thank you all.
Thank you so much, sir. Thank you so much. I know that, Dr. Rita ma'am and sir have been sitting and choosing this for the last 48 hours, 2 days, because it was more than 30 echoes that they have chosen from. I think there's so many more which were so rare. We have to go back and open the patient history and see, oh, this is what we have seen ourselves 4 years back. It was that rare. I request ma'am to continue this with a very interesting case, which brought in 3 departments as she described to you.
Good evening, everybody. So I will follow all towards the fag end of the day. This is the last case that I'm presenting. And soon after this, we will be going towards the hands-on, which we will be doing as soon as possible. So please bear with us. This is a case of a 37-year-old male with diagnosed Marfan syndrome clinically and was symptomatic, and also had a family history of similar illness and I think father who had died at 49 years of age. His echo showed an aortic aneurysm in the ascending alpha with moderate to severe AR. This is the sagittal section of the CP during the aneurysm. And the 3D reconstructed image showing the large ascending alpha aneurysm with severe AR. CT report was also confirming the same, and so the patient was taken up to surgery. And this is the intraoperative images on the left side. As you can see, this is the morning time around 10 o'clock before going on bypass. They've taken the images, severe AR is noted, and any function is good. In the evening, of course, the AR was done uneventful. 27 ppk Chitra valve was good, and there was aorta root replacement was done with a woven polyester down. Same evening, there were cold volumes, decreasing urine output, rising serum lactate, and metabolic activities. But arterial pressure of the radial artery seemed to be good. So we had an issue here. We could really function with dropping urine output, and we had to figure out what was happening. T was done. This is the left image shows the morning T, which is at 10 a.m. And this is the right sided shows the evening 9 p.m. T image. And it shows that there is a flap and there is a large false lumen which is compressing the true lumen, and a trickle of flow seen in the true lumen. So this was what it was like. Somewhere at the distal edge of the graph there was a dissection which had probably cracked down, and the patient was intubated. Yes, there was no retrograde access to the leg because the dissection probably had gone way down. So we took a left brachial access and we went in hoping to inject and find out if there is a true lumen and if we could get any entry into the true lumen. So this is at like 10 p.m. in the night of that day, and we were trying to enter the true lumen. We knew we had very limited hardware on the shelf at this point, but something had to be done. So on injecting, we found that there was no distal drug off. Actually, the distal flow was very poor, and so we went in initially with T guide. Showing this case here only because T really helped us. So these are our T pictures at 9. So the case starts at 9 p.m. Sorry. It goes on to late in the night, as you can see. There's a false lumen which is having a lot of flow there. We are not able to enter into the true lumen. The soft end of the wire kept getting deflected, and we had a continuous anesthesia support. And this is a better picture which shows that yes, okay, we were making entry into the true lumen. in this, I think this was where we sort of knew where our wire was. We had taken a straight wire finally trying to perforate, because after discussing with a few experts, they told us just try to enter the true lumen and try to just perforate that flap, and you will have established some flow to probably salvage the mission. So this is how, with our T guidance, we went ahead and the communication was definitely poor, but eventually we managed to point it towards the flap and perforate. So by this time it's already 12 a.m. and somewhere we have perforated the flap to some extent, and at some point, and then we had to track down a balloon, and we just did balloon dilatation across that point. And eventually, the true lumen looked bigger and slightly better than what it was.
Can
But that
actually
was
see it.
what we could do at that point in time at 12:30 a.m. when we entered this case. That was all we could achieve, and we left the patient at that. But again, we thought we'll come back again with a better plan with more hardware. So we had to procure the stent, and this is in the earlier part of this year where actually COVID was still not gone, the third wave in India. So we had some difficulty procuring the stent, and it came late in the night on the next day. So again we are back at 10 p.m. entering, but then another day, and this time actually surgeons had. These are the angio pictures of the same day. Let me just show you. So this is the balloon dilatation and all that. It's all the same day, first night. And I'll show you the next images. So this is all on the first night itself, trying to, we were going in from false to true and trying to do the perforations. And finally, at the end of this whole thing, the true lumen looks slightly bigger and better. That's all I can say. So we went in again the next night, again late night, we needed the larger stent. We did not have a covered stent. This time we went in a little better prepared. The surgeons gave us a cut down with subclavian, and we again had to follow the same route, and this time we were luckier. That since we had the stent, it was not a covered stent, but it was a bare stent, but we went in with the hope that it would at least scaffold the flap and we would still get some distal flow. And that was what we achieved with P guidance again, just confirming that we were in the true lumen. So this was our stent deployment and extraction finally. And the patient did well for a few days. Initially, actually that very night we had some urine output also, and the patient did well. And that was when after the first night itself, we started getting urine output. On table itself, we saw the patient clinically improve. Distal pulses had come back, feeble of course. But so that was when we decided that we'll go ahead with the stenting. So after the stenting, we have again expanded the stent post-stent dilatation was also done. So for me, the take-home difference was, yes, it was T and team. T and team was what actually made the difference to this patient. And it was a difficult patient to deal with, but this was what we had. And T was really the game changer, because otherwise it was impossible for us on angio to identify true versus false and other things. So thank you very much for your kind attention. We'll be announcing the groups into which you will all